morning, everyone. A very, very warm welcome on this morning. I know it's hard on a Sunday morning to come over and attend a scientific program. We will try our best to deliver, and we will try to make sure that by the end of the day, you won't regret. We have lined up a number of excellent lectures from a very, very eminent faculty during the day. We have 40 plus faculty members. We have 25 lectures in this program today, covering a wide variety of various cardiology topics. For the main theme is towards prevention. We are, without wasting any time, we are going forward. We are going to start session 1. I have a request for all the speakers and the moderators to please make sure the time. The timing is the essence of the success of the program. Although I know that sometimes it is very difficult to abbreviate what you want to say, nevertheless, we have to stick to the times. That is my only request with all humility. So we are starting the first session in the morning, and I have the pleasure to invite Dr. P.K. Gupta as one of the moderators and chairpersons. Dr. Gupta has been always with us every year after year. And for last many years, he is in India, and he makes sure with all the difficulties, he joins the program. The next is Dr. Peter Otasevic. He is in Serbia, and he will be joining us online. I can say him hello if he is there.
Hello, I'm here. Hello, it's great to be here.
Dr. Jairam from Abu Dhabi, my wonderful friend. So I leave the floor for you to start the proceedings of the first session.
Good morning, ladies and gentlemen. And at the outset, I would like to extend a very warm welcome to each and every one of you. We have got a very exciting day ahead. And to kickstart the first session, basically this session is dedicated to acute coronary syndromes. And the first speaker is known to all of you. He doesn't need any introduction. Dr. Brajesh Mittal. He is the Deputy Medical Director as well as a Consultant Interventional Cardiologist and Head of Cardiology, Medcare Hospital, Dubai, as well as he's the Chairman of the Sheikh. So he's going to talk on STEMI care, intervention to prevention. Dr. Brajesh.
Thank you, Dr. Gupta. So this is a talk which is adopted and inspired from a session in TC 2024 Washington, D.C., which I had attended, and I was so impressed by the whole session that I tried to abbreviate into a smaller one. And this is actually setting the stage for today's whole entire day's proceedings. Typically, we have patients like this. This was a patient of mine. Some of my colleagues are here who were there at the time of this case, 66 years old, male that time, 5 years back, acute inferior wall MI. And he underwent a primary PCI with a very high thrombotic burden, and the result was very successful. The important thing to note here is that we believe that after doing the primary PCI, we have done everything, but that is just the beginning. Successful PCI is only the beginning of treating these patients. The treatment starts now. So we got to know that first time he was diagnosed to have primary hyperlipidemia, grade 1 hypertension, type 2 diabetes, which HbA1c 7.6, and also incidental finding of moderate MR with mitral valve prolapse. Subsequently, during the course, he developed paroxysmal AF and he got mitral valve repair. So he is on beta blocker. He is on a combination of atorvastatin and ezetimibe. He is the first patient of mine and also perhaps in the UAE to receive inclisiran injection. That was way back in May 2021. Metformin, Epic-7 and vitamin D. He is doing very well. He walks every day and his treadmill was absolutely normal. His echo had minimal wall motion abnormalities, and you can see all the parameters are very well controlled. So now, up to now, we believe that everything has been done right and nothing else could be done, but actually that's not the case. There is still more we can do besides that. Why do we need all this information? Why do we need all this knowledge? Because recurrent MI is a real menace. It is common and it is disastrous. A recurrent MI carries a higher mortality and morbidity over 5 years, up to 50%. So our aim is that first MI is nobody's choice, but second MI is our responsibility to prevent, the patient's responsibility and our responsibility, and we should do all what we can do. So in the current era, we redefine the residual risk for the recurrent myocardial infarctions, and residual risk parameters are cholesterol control, for which LDL is the marker. Then there is residual inflammatory risk, which can be assessed by the high sensitivity CRP, residual thrombotic risk, for which we do not have an actual marker. Then there is residual triglyceride risk. We consider now that it should be less than 150. And there is residual lipoprotein A risk, which we are not checking regularly in our patients, but we have started doing it now. And then the control of diabetes. There have been significant gaps in secondary prevention despite all this knowledge. The gaps are more than 30 to 40% in the management of these patients. It was shown that non-adherence is more in those patients who are given shorter supply of medications at the time of discharge. So if you give 30 days medication on discharge versus 90 days on discharge, the 90 days people have more adherence to the medication, as well as polypill clearly improves the adherence. Besides that, a very forgotten part which we do not apply in our patients is the cardiac rehabilitation. Clearly you can see the curve separating, that survival is far better in those who underwent a proper cardiac rehabilitation program. Then we often believe, and we are doing it right from the ages, that we give aspirin as a secondary prevention to everybody. This has been questioned this was questioned actually in 1996, and also with another trial, host exam trial. And now we have the smart choice trial recently presented in ACC 2 weeks before. So now we clearly know that clopidogrel is a superior choice as a secondary prevention as compared to aspirin, and it does not cause more bleeding. The next concept is regarding the dual antiplatelet therapy, and we should know that dual antiplatelet therapy duration depends whether you have treated the patient on an ACS basis or CCS basis, what kind of a stent you put, or was it a drug-coated balloon, or what is the bleeding versus thrombotic risk, and we have to balance all this, and then we have to decide the duration of the dual antiplatelet. The possible shift in paradigms for lipid-lowering therapies, together with anti-inflammatory therapy from day one. Now we believe that cardiovascular disease is an endothelial dysfunction and mediated by which involves a lot of inflammation from different pathways. So there are clearly anti-inflammatory effects of statins. So what is the dictum for lipids? Act early and treat aggressively. So now, as of now, we know that high intensity statins or plus minus ezetimibe and quicker use and earlier use of PCSK9 inhibitors and inclisiran do value a lot, and there are several trials of this nature to prove. Onset of benefits of statins in ACS starts very early. If you start high dose statin, a high dose atorvastatin, earlier the better, and better is the outcome. High sensitivity CRP is a surrogate marker, and it's a better marker in this trial. At least we can show that as compared to LDL, HSCRP proved to be a superior marker to predict the cardiovascular deaths. There's been a lot of controversy about colchicine. There is a LODOCO-2 trial, colchicine in patient with chronic CCD, which clearly showed that colchicine improves the long-term prognosis. Also in the COLCOT trial, although the trials, the most recent trial last year, CLEAR-OSS 9 trial, failed to show in acute MI patients the benefit of colchicine. But one thing was clear, that colchicine also acted upon CRP and reduced the CRP. This is the very latest trial 2 weeks before, which was presented, Ekstrom colchicine trial, and it showed that there is clearly there is a significant plaque volume progression is reduced as compared to placebo with the use of colchicine. So colchicine is now in the guidelines. ESC has given for both class 2 indication for ACS and chronic coronary syndrome, while American guidelines have only given for acute MI situations. Then we do not usually look for it. Influenza vaccine. Influenza vaccine, there's 5 published RCTs which clearly showed the superiority of influenza vaccine because of its anti-inflammatory act and a better hazard ratio. And actually it was shown for hard endpoints like primary composite endpoints, the all-cause death and cardiovascular death, except in myocardial infarction. So we do not look like in our patient that whether we gave or are we giving influenza vaccine or not. So anti-inflammatory action is the most important nowadays. In ACS, statins show early benefit. Anti-inflammatory effects may explain early benefit. IL-1B inhibition, which is also inflammatory marker, shows cardiovascular benefits in prior MI. Colchicine has been shown to demonstrate benefit, and there are ongoing trials of IL-6 inhibitors. Lipoprotein A, presence of lipoprotein A increases the attributable risk of cardiovascular death or MI. So we should always look for lipoprotein A. So all these things I have not mentioned in my patient, which initially we thought we have treated very well. And then there is an emerging concept of CKM syndrome. We have a full session today, this afternoon, on CKM syndrome, a connection of heart disease, kidney disease, diabetes, and obesity. And you can see at the bottom of this that if a patient has diabetes alone, the risk is 7.7%. If CKD alone, risk is 11.5%. But when the two are combined, the risk is actually proliferated. It is not just a sum of these two individual risks, but it is 31.1%. So these proliferate each other, and CKM is a very, very emerging new concept in the current situation. So friends and colleagues, this is a summary of this presentation, that intervention to prevention has several facets. Early and aggressive lipid-lowering therapy, attention to high-sensitivity CRP, lipoprotein A, and triglycerides, besides LDL, address inflammation, statins are anti-inflammatory, colchicine is anti-inflammatory, influenza vaccine prevents inflammation, IL inhibitors are under development, methotrexate, daraliprib, etc. Then appropriate antithrombotics, proper duration, proper intensity, de-escalation, or maybe longer execution in the high-risk patients. And consideration of clopidogrel over aspirin, then cardiovascular kidney metabolic syndrome, one should take into consideration. AI-tailored algorithms with electronic medical record and polypill, larger prescription fills, incentivization for guideline-directed medical therapy and target achievements and adherence, and cardiac rehabilitation. So this is all what we should look for, and things, and this list keep expanding, and we keep reducing the cardiovascular mortality and morbidity. Thank you so much.
Thanks, Dr. Brajesh, especially for the 2 points. One, he completed his talk before the time, so he has set the agenda for others that everybody should try to stick to the time. That's number one. Second, he very eloquently highlighted the role of residual risk in recurrent MI and how to deal with it. If any query, we will take at the end of the session. Thank you, Dr. Brajesh.
Thank you.
Good morning, all. We now invite Dr. Amir Faur. He's a consultant interventional cardiologist at the Medcare Hospital to deliver his talk on From STEMI to Occlusion MI, a paradigm shift. Welcome, sir.
Thank you, Dr. German, Dr. Gupta, and thank you, Dr. Metal and the organizing committee for inviting me today. So my talk today is titled From STEMI to Occlusion MI, Paradigm Shift. So I think it's a very exciting time to be doing cardiology at the moment, because we, or at least I believe, and several other people, emergency physicians, including cardiologists, believe there is going to be a big paradigm shift in terms of the nomenclature for classifying acute coronary syndromes. And the shift will be from the dichotomy of STEMI, non-STEMI, to occlusion MI, non-occlusion MI. And we've seen this over the last decade, and it's being filtered slowly into the guidelines. So before I start my talk, I'd like to briefly touch on the Kuhn cycle, which is basically an idea mentioned in The Structure of Scientific Revolutions, which is a book published in 1970 by an American philosopher, Thomas Kuhn, and he was also a historian, and he argued that normal science goes through undulations or phases. And normal science is based on a paradigm which we use every day to guide our decisions. And we encounter anomalies or things that we can't explain. with our current paradigm. This causes chaos or uncertainty. Novelties occur, or people then try to understand why these anomalies occur. Either they're absorbed into the current paradigm, or eventually the paradigm changes and shifts to a new paradigm. And this occurs in many different disciplines in science. And for cardiology, particularly for acute coronary syndrome, this has occurred. Initially, we've moved from the Q-wave paradigm to the STEMI paradigm, and I think over the next few years, we're going to accept, more of us are going to accept moving to the OMI paradigm or the occlusion MI paradigm. And so I'm just going to give a brief history on how we got to where we are. So in the pre-thrombolytic era, patients with MI were admitted to hospital, they were observed. Essentially, intervention was not part of the treatment plan. We were treating complications. Subsequently, after the release of multiple thrombolytic trials and meta-analyses, the STEMI paradigm has evolved, allowing us to identify patients with a simple tool such as ECG that would benefit from thrombolytics. And the guidelines then dichotomized and classified patients with suspected MIs having ST elevation or new onset left bundle branch block to guide reperfusion therapy. And that's where the STEMI non-STEMI dichotomy emerged. But if you take a look at the evidence behind actually ST elevation criteria, it all began after the publication of the seminal fibrinolytic therapy trials meta-analysis, in 1994, where it showed up approximately 60,000 patients. There was a benefit from thrombolytics compared to placebo. The number needed to treat was 56. However, a closer look at the trials in that meta-analysis that were included in the meta-analysis, 4 out of the 9 trials did not require any ECG changes. You just had to suspect someone had an MI, and they qualified for thrombolytics. And in fact, 1/3 of patients had no appreciated ST elevation. Despite this, there was a mortality benefit. If you look at the subgroup analysis, if you use an undefined degree of ST elevation as an arbiter of thrombolytic administration, so in the patients who had any degree of ST elevation, the number needed to treat improved from 56 to 43. Patients who had ST depression or normal, which weren't defined, showed no significant benefits. So this suggests that using the ECG predicts occlusion better than not using an ECG at all. And so there's a limited evidence for the STEMI criteria in predicting acute coronary inclusion. These patients, as I mentioned earlier, the trials, some of the trials included patients just with suspected MI with limited or no ECG requirements. And the ECG interpretation was crude. Basically, there was no detailed granular measurements of how much ST elevation. Bundle branch block was in fact a combination of any bundle branch block. It wasn't left or right bundle. You just had to have any left bundle branch block. The subgroup analysis separated that. ST segment depression not defined, and normal wasn't defined. So in fact, if you look at the conclusion of that trial, it says withholding reperfusion therapy in patients without ST elevation, you should be cautioned about not giving anyone reperfusion therapy just because they don't have ST elevation, because the numbers of death in those subgroup analyses were small, and withholding this reperfusion therapy may not be a good idea because of the number of deaths that we're seeing. So going back to where we are, and where did these STEMI criteria come from? We know that the fibrinolytic therapy trials showed that ST elevation or bundle branch block is a criteria for thrombolytics, but subsequent to that, seminal studies by Minon and Professor McFarland showed that ST elevation of the current criteria that we use were actually, these studies use CKMB as the gold standard to define MI, not coronary angiography. And then in 2024, D. Alenkar looked over the last 30 years, they found only 3 studies verified the diagnostic accuracy of ST elevation criteria based on acute corneal occlusion. So only 3 studies, in fact, looked at angiography to define if you had ST elevation, what is the sensitivity and specificity for acute corneal occlusion? And the sensitivity is only 43%. So STEMI criteria misses a significant number of patients with ST elevation. And so we come to the next limitation of the current STEMI criteria. There are no false negative paradox. If the ECG meets STEMI criteria and the patient has acute corneal occlusion on corneal angiography, that's a true positive STEMI. If the ECG meets STEMI criteria, but there's no culprit lesion, that's considered a false positive STEMI. However, if the ECG does not meet STEMI criteria, but the patient goes to angiography and there's an acute corneal occlusion, that's not considered a false negative STEMI. It's considered a non-STEMI. So this results in, delayed reperfusion for a patient who should have gone immediate angiography, merely because he was labeled as non-STEMI based on the initial ECG. And so this leads to incorporation bias, okay, because the index test is actually the reference standard. And so, in fact, the discharge diagnosis, I'm sure this occurs in many institutions, if a patient comes with sub millimeter ST elevation that's required for the traditional STEMI criteria. They go to the cath lab within 18 hours or 20 hours. There's a completely occluded LAD. The discharge summary will still state non-STEMI, when in fact we should be moving towards occlusion MI or not occlusion MI. The non-STEMI trials can also be interpreted or misinterpreted in the wrong way, whereas a lot of the trials were negative in terms of outcomes, in that showing that early or immediate reperfusion did not improve outcomes. A closer look tells a different story. The TMAX trial published in 2009 showed that early intervention didn't change the primary outcome. But if you look at what was the median time to intervene on these patients, it was 16, where most of the myocardium would not be salvageable by then. Looking at the verdict trial, which included unstable angina patients, in fact, it showed a benefit for high-risk NSTEMI patients if they were treated within under 5 hours. And the Riddle NSTEMI study showed lower mortality in patients who received immediate reperfusion. And so an important thing to remember is that these trials excluded patients with refractory ischemia because the current guidelines suggested if you have any patient with ongoing symptoms, they should go to the cath lab immediately regardless of the ECG. And so early STEMI anomalies that gave rise to this search for a new terminology. Some of the things that were noticed early on: posterior STEMI. There's no ST elevation, yet there is ST depression in a characteristic pattern, and you often find an occluded artery. There are some signs to suggest inferior occlusion myocardial infarction without the traditional criteria for ST elevation. And there's also the changes seen in patients who have conduction disease, such as Scarboza criteria. So all of these things need to be explained in a way better than the STEMI, non-STEMI dichotomy. And so over the last 10 years, there have been more and more patterns that would suggest acute corneal occlusion, such as the South African flag pattern, which suggests a diagonal occlusion, Ash-Langer pattern, which suggests an inferior STEMI and occluded RCA in the presence of concomitant left-sided disease, the D-Winter pattern, hyperacute T waves, and so on. All of these do not present with your traditional ST elevation that you were typically trained to pick up, and all of them have a high percentage of a completely occluded artery. So these anomalies gives rise to these questions and crises, if you like. Guidelines acknowledge these limitations. However, the paradigm is maintained. And so there's a debate over should we still be using the STEMI, non-STEMI paradigm, or should we be moving to a more appropriate paradigm? And so the OMI paradigm emerges, first published in a blog, actually, believe it or not, in 2018, called the OMI Manifesto by Smith and Myers. Subsequent articles has been published since then. And I think we're going to be seeing these incorporated into guidelines soon. And so how do you define occlusion MI? So it's an acute culprit lesion with reduced flow, or acute culprit lesion with normal TIMI flow and a very high troponin. As you know, because almost 30% of STEMI patients can undergo reperfusion spontaneously. And finally, for patients who do not undergo angiography, a very high peak troponin and new regional wall motion abnormalities. And so studies comparing the current STEMI paradigm and the OMI paradigm showed increased accuracy. So in the one in the middle, Myers looked at expert OMI interpretation versus current STEMI criteria, and the sensitivity is doubled, increased from 41% to 86%. And so finally, just because I'm short on time, I'll finish with my last slide. I think in the future, there's going to be advanced ECG interpretation, combining other criteria other than STEMI. Clinical assessment will be important. So if a patient has ongoing symptoms, we should not ignore that. Bedside echocardiography should be used to look for regional wall motion abnormalities, and systems of care should combine all of that to try to improve the detection of patients with acute coronary occlusion. Thank you very much.
Thanks, Dr. Ahmed. I think in the interest of time, we will want to come upstairs. Thank you. Thank you, Dr. Ahmed. We'll move on to the next lecture. It's from one of the doyens of cardiology here, Dr. Rajiv Loshan. Needs no introduction. He's a consultant interventional cardiologist at the Al Zahra Hospital. Welcome, sir. And he will take us through navigating the gray zone, managing common dilemmas in patients with acute coronary syndrome.
Good morning, Dr. Gupta, Dr. Jairam. First of all, I should congratulate Dr. Mittal for continuing this education program for almost a decade. And it has been seen that in the morning session, you can see so much attendance. It shows the interest of the people in the caliber of this education program. So he has given me talk today to discuss the navigating the gray zone and managing common dilemmas in the acute coronary syndrome. How to move the slides. So gray zones, when we talk about acute coronary syndrome, generally described by the three typical areas: ST elevation myocardial infarction, which we don't know whether after the paradigm shift we'll have to change the name. Dr. Amir has really brought some very interesting concept which we have to understand. Or non-ST elevation myocardial infarction and unstable angina. Why they have been described? According to me, because that all three have different treatment modality and how they have to be managed. So, however, some of these ACS patients presents with complex situations and the management become challenging. And that's how we come to the area where we can call it as a gray zone. So I'll discuss some of these situations like cardiac arrest with a STEMI requiring prolonged cardiopulmonary resuscitation after a ROSC or return of spontaneous circulation, management strategy, what it should be. Should the patient be taken directly to the cath lab for primary PCI just to maintain door to volume time within the range, or initial conservative management should be done? And once the hemodynamic is stabilized, then we should go forward to the next invasive management. Cardiogenic shock with non-STEMI, should the patient be treated conservatively as compared to STEMI? It is generalized ST depression in all the leads, ST elevation in MR, AVR, which we commonly takes a sign of ST elevation like a left main stem block or proximal LAD block. Should this patient be taken directly to the cath lab? So all these areas are little undefined. I will take help of some of my clinical cases. The first patient is 46 years male, fainted at work. Thanks to the training of the general people, non-medical people having a training in CPR. So one of the colleagues, his co-workers, he did a CPR with his capabilities, and luckily defibrillator was available, so DC shock was given before the medics came from the ambulance, and then they took over and continued CPR. The CPR was continued in the ambulance almost for 30 minutes, and they have repeated shocks, and amiodarone was given for VF and arrhythmia, and patient was brought in ER with hypotension and hypoxic state on ventilation oral airway support, which was replaced as he came to the ER. ECG showed hyperacute ST elevation in anterior MI. Blood pressure was 90/60 on norepinephrine. Now the question was, should this patient be treated conservatively or primary PCI? Another caveat was this patient had a fall, so he had some bump in his head, whether the patient should be taken to CT head first. So because of this various dilemma, they did not find any neurological signs. So this was the ECG, and we took a call and we took the patient to the cath lab. So looking at the guidelines clearly says primary PCI strategy is recommended in patients with resuscitated cardiac arrest if the ECG shows persistent ST elevation or equivalent like LBB or new bundle branch block changes as a grade 1, and all enthusiasm of taking all patients of the cardiac arrest to the cath lab has been declined, like a grade 3 category has been given. And if you are in a hospital which is a PCI is not available, patient should be transferred to another facility. And this was ECG angiogram, which shows total block and proximal LED. As soon as the guide wire was advanced, the flow restarted and angioplasty was done. So in the management which we did, patient was taken to the cath lab, primary PCI done, clinical condition better, hemodynamics close to the dose of norepinephrine was reduced, ventilatory support was continued. Patient developed secondary liver damage because of the continued hypotension and acute renal failure, which required hemodialysis. And clinical course of the patient was he required prolonged ventilatory support in ICU. Dialysis was continued, signs of cerebral anoxia, convulsions requiring anti-epileptics, and could not be weaned off from the ventilator for long 26 days in our ICU. And he did never gain the consciousness. Then he was airlifted to his family in India with a bleak outcome. We don't know what happened later. So as a retrospective thought process, should patient be sufficiently stabilized out of the hospital after the out of hospital cardiac arrest before we take him to the invasive ventilation, or patient when off ventilation, hemodynamic support, and then we should have taken forward. So recently, the adult cardiovascular life support ACC-AHA protocol focused on the update 10 top takeaway point. I just highlight one which includes is associated with our patient. Emergency coronary angiography is not recommended over delayed procedures, and it should be shock, and if there is the associated signs of significant myocardial damage, only then it should be considered for invasive management. So for that reason, it looks logical what was done, but still there are some doubt remains what was the management was the best. Case 2, cardiac arrest. This is a 54 years female bank executive having unbearable chest pain. While at work, she drove herself to a ER. On arrival, and as soon as the ECG was being recorded, she developed VF, and it was resuscitation effort was started, shock was given. She regained consciousness. She never had a unconscious state for a long time. Rhythm was restored. Patient was transferred to another facility or a PCI facility for an invasive management. Although it took more than 120 minutes, proximal LED total block was correlated to anterior MI, primary PCI was done, and direct stenting was done in that patient. Echo showed anteroseptal MI, not surprising, as anterior MI low ejection fraction. Patient was regularly followed up for a couple of years after that recovery. EF improved over a period of time to 50%. Clinically, she was an NYHA class 2 and regularly walking 3-4 kilometers. Now, discrepancies, if you look at it, patient was in STEMI, transfer PCI, expected recanalization time was more than 120 minutes. She should be thrombolysis be given before transfer, as most of the guidelines say. If you expect time delay, thrombolysis should be done. No thrombolysis was offered as CPR was done. May also be logical because after CPR, you may have more complication if you do thrombolysis. Recovery of EF, even after the delayed PCI, which was more than 120 minutes, was interesting. So she recovered. So all these things which are given in guidelines, we don't know what we get in practice. So there is a gap, definite gap. If you compare the scenario in two patients of cardiac arrest, case 1 out of hospital, unwitnessed cardiac arrest, prolonged CPR, shock given, and poor outcome even after short door to balloon time after primary PCI. Case 2, in contrast, in hospital, witnessed cardiac arrest with immediate and DC shock given, effective CPR under ACLS protocol resulted in quick return of spontaneous circulation without any ventilatory hemodynamic support and had a very good outcome. So these two cases gives us some guidelines or understanding how these two patient presentations should be differentiated in our management plan. Case 3, 76-year-old male presented with subdural hematoma following a fall from the bed. Hematoma was evacuated surgically. Paroxysmal AF developed while patient was still on ventilator. During the recovery, cardiac markers were markedly elevated, troponin to 122. ECG showed tachycardia with generalized marked ST depression and almost all lead and ST elevation in AVR, which we normally take a marker for proximal LAD or left main stem block. AF reverted with sinus rhythm with amiodarone and beta blocker rate was controlled. This is ECG. I hope you all agree. This looks ghastly ECG. ST depression and most of the leads and except an AVR. And this is usually we have a teaching, and I'm sure one of the doctors in our meeting today, she referred this patient from a non-PCI center for angiography. And in the bottom is the ECG, which was before. So you can see the difference and nobody will disagree. This raises the concern of left vein occlusion. But because of the because of the hematoma, subdural hematoma, recent surgery, I was not ready to intervene because I had a concern of giving anticoagulants with the cerebral bleed, what we should do. So management usual, subdural hematoma was surgically evacuated, rate was controlled and troponin showed decreasing pattern. So diagnosis of the LMCA was there, but we did it conservatively. Interestingly, angiogram showed a normal coronary, almost normal minor plaques. So at retroscope, was there a need for invasive procedure, primary PCI immediately or after craniotomy? How should one should trust the ECG findings or troponins in this situation? So in the recent ACS guidelines, ESC, they have given a list of gaps in the availability of the data. So these are the various lists like biomarkers for early detection and CTCA or treadmill. I will not go in details of all of them, like FFR or IVUS use or OCT use in assessment. So these are the various areas which we don't know exactly what should their status. So how to fill in the gaps in the diagnosis of ACS and out of hospital cardiac arrest? The important is to take a detailed history, event, exact time gap, CPR, delay in DC shock, quality of CPR, and how the ROSC was obtained, whether the consciousness was there, primary PCI after CPR to be modified, not dependent on just the door and balloon time, abnormal troponin, STEMI ECG changes with tachycardia needs to be individualized. And these guidelines give direction, but may not be the perfect arrangement. So I've tried to highlight one area of out of hospital cardiac arrest and after return of spontaneous circulation, we can divide them in two groups. And this pathway shows one the non-conscious patient or non-comatose patient and comatose. Non-comatose patient, STEMI, even with the arrhythmia or electrical instability, should go directly for primary PCI. On contrast, comatose patient, non-STEMI, primary PCI or delayed invasive protocol or treatment has almost the same treatment in terms of death, disability, and outcomes in the coma status dependent on the randomized trial. That's Cohort, Tomahawk, and these are the control trials and more minor, smaller studies that emerge, Pearl and Cube ST. They all supports it. In between the patient where there's STEMI with incomplete recovery, either neurological or hemodynamic, which needs to be re-evaluated. If you have incomplete information of duration of CPR and a number of other associated parameters, these needs a individualized care rather than spatial take away same status. So I would just conclude at this one. Acute coronary syndrome incorporates wide range of cases. Degree of area is diverse and it is associated conditions. Guidelines helps in giving direction, but they are not applicable in each patient. Detailed history, clinical finding, associated comorbidities have significant role in management planning. Each patient may need tailor-made treatment to fill in the gaps in challenging situation for better immediate results and long-term outcome. Even out-of-box solution sometimes may be considered in these cases. Thank you.
Thanks, Dr. Lochan, for highlighting the gaps in the guidelines.
Thank you very much. Thanks.
So let's move on to the last lecture of this session, and that's the guideline-directed antiplatelet therapy in CAD, implication for clinical practice by Dr. Georgie Thomas, consultant interventional cardiologist, Burjeel Hospital, Abu Dhabi. Dr. Georgie.
Thank you, Dr. Gupta, Dr. Jairam, Dr. Mittal. Thankfully, I still haven't lost my voice with the onset of a sore throat as of yesterday night. Guideline-based dual antiplatelet therapy, we just start up with, which is the forward. Okay. So the main objectives are we try to understand the drugs that we use, discuss the selection of the different antiplatelet medications, use the current practice guidelines to use these drugs, determine the optimal duration, and assess the cardiovascular bleeding risk. Understand the drugs that we use. Here comes the fun part. Platelet, the main culprit of all of this, the dark horse in all of our games, where we try to treat patients, platelet gets clumped, we get into trouble, patient gets into trouble. So the platelet is the number one villain, and this is the villain that we're trying to suppress. So the platelet has two zones, the fibrinogen GP2B3A zone and the ADP, ATP cycling, which are all responsible for platelet clumping. What are the antiplatelet agents? We have a galaxy of stars in this: aspirin, NSAIDs, GP2B3A inhibitors, P2Y12 inhibitors, phosphodiesterase inhibitors, cyclic AMP inhibitors, and PAR1 receptor antagonists. Now let's go into the most important and well-known villain of all. Most well-known, most understood, and most misunderstood. Can anyone in the audience or anybody in the audience guess what the half-life is? Quick. I don't have time. What is the half-life? This is a very simple and fundamental question. What is the half-life of aspirin? Anybody? Show of hands for 7 days, show of hands for 5 days, 1 day. What do you think? It'll be very surprising. See, it's only 20 minutes. Right? You learned something new today. Aspirin half-life is only 20 minutes and it does the required job in those 20 minutes. It inactivates the cyclooxygenase 1 and thus blocks the thromboxane A2 synthesis for the life of the platelet. The platelet lives for 7 days and it cannot regenerate COX-1. And that is why the action of aspirin lasts 7 days. However, that is for the platelets that are there today. What about the platelets that are born tomorrow? Then you need to give a new dose of aspirin for tomorrow. And therefore the aspirin cycle continues. But remember, once you've ingested aspirin at 7 a.m. today, by 7:45, aspirin is out of your system. Therefore, why is this important? Because transfused platelets will work normally even in patients taking chronic aspirin. So if you have a bleeding issue, you can immediately give a platelet transfusion and those platelets will deal with the bleeding. Next group, GP2B3A inhibitors. We have eptifibatide, tirofiban, and abciximab. We thank the pharma industry and especially the pharma researchers for making tongue twisters for names. I wish they had easier names. Now, the fundamental thing is there is no additional benefit in patients pre-treated with clopidogrel. So if you're using tirofiban or abciximab or any of these drugs, if the patient is already treated with clopidogrel, the ISOREACT trial, an older trial, says that there was no use of giving these GP2B3A inhibitors. Head-to-head, abciximab was supposed to be more potent than tirofiban in most of the trials. But again, by the end of 1 year, everybody had the same outcome. Eptifibatide activity was similar to abciximab, and these are the 3 trials that are currently looking at these drugs and saying which one is better. Probably the pharma industry wants to figure out who's better and what not. Abciximab remains the most costly. Next group of drugs is clopidogrel, prasugrel, ticlopidin, ticagrelor, and cangrelor. These are all classified as P2Y12 inhibitors, and they are classified as reversible and irreversible. So the reversible group is ticagrelor and cangrelor. The irreversible group are clopidogrel, prasugrel, and ticlopidin. Pharmacodynamics, pharmacokinetics, these drugs are thienopyridine drugs activated by the cytochrome P450 and are actually irreversible. They have longer half-lives and therefore can impact transfused platelets. So remember, I told you in a patient taking aspirin, you can transfuse platelets, but in somebody taking these thienopyridines, even if you transfuse platelets, the platelets might work and then these platelets will get affected by the drug and therefore they become inactivated. Now, very important, prasugrel not available in UAE, but it is useful in the polymorphisms. Platelet transfusions may help, but may require multiple transfusions. What about ticagrelor? Brilliant as we know. It's a pyrimidine analog. There is no need to convert metabolically to an active form, rapid onset of action, rapid reversal of action. Now, why did I put up the slide? Cangrelor. It is the latest player on this field. It is the first and only intravenous P2Y12 inhibitor. So consider it as intravenous ticagrelor. Direct acting, reversible immediate onset of action with a half-life of 3 to 6 minutes. Rapid offset as well. How does it compare? Because cangrelor is IV administration, the others are oral. You have an onset of action within 2 minutes, a 98% per platelet inhibition. It is reversible, so you stop the infusion and within 3 to 6 minutes to 1 hour, the platelet function returns to normal. The efficacy of this is more important in patients who cannot take P2Y12 inhibitors orally, as in people who have delayed viability, you have a resuscitation happening, patients having vomiting, difficulty in swallowing due to mechanical ventilation, hemodynamic instability, all conditions in which you administer clopidogrel or ticagrelor orally. This will not be absorbed for your use in PCI or ACS. So that's where cangrelor steps in. Dipyridinol and silestazole have been studied. Dipyridinol's role is predominantly in stress and SPECT, but has not been used in coronary artery disease. Silestazole, quite a few trials saying that it works in triple drug therapy with aspirin, Plavix, and silestazole as triple drug therapy, but somehow it never made it to the mainstay. Of course, everybody knows why we use sildenafil, tadalafil, avanafil, and vardenafil. Absolutely, we don't try to use this in coronary artery disease, definitely. Last is the PAR1 or thrombin receptor antagonist, Vorapaxar. Again, the trial suggests it's a new drug, orally selectively acting inhibitor of thrombin receptor, reversible but has a very long half-life, up to 4 weeks, and predominantly currently being used in peripheral artery disease. So, how do we select these different antiplatelet drugs? Fundamentally, it sounds very difficult, but if you look at this table, you administer aspirin at the initial 10 minutes of presentation. And then we decide whether we're going to go into invasive or non-invasive. The interesting part is if you look at the left side, everybody gets ticagrelor, everybody gets clopidogrel, whether you do invasive or not. So the whole fundamental of this table sometimes is lost because if you actually look, everyone almost gets everything. If you have an invasive strategy, will angiography offer in the next 24 hours or not? If not, obviously they get ticagrelor. Wait until diagnostic angiography is complete. And after angiography, what is the plan for management? If it's PCI, CABG, or medical management, the entire extreme side, ticagrelor is preferred, and those who can't take Brilinta, they get clopidogrel. But on the left, there's an interesting slide piece. If you have a history of stroke or TIA, you prefer ticagrelor or clopidogrel, but never prasugrel. So, what is the current guideline for the management of antiplatelet therapy in coronary artery disease? Fundamentally, we use DAPT in acute coronary syndromes, post-PCI for stable CAD, in stroke or TIA, peripheral arterial diseases, CABG. Now again in CABG, remember if you do a CABG for acute coronary syndrome, you would use DAPT for 1 year. If it's an elective CABG in coronary artery disease, the guideline is only to use aspirin compared to a lot of our doctors which actually use aspirin and clopidogrel even after CABG. So further down, DAPT is recommended for patients in ACS. The preference is for Brilinta or prasugrel. You have to continue dual antiplatelets for 1 year in those with low bleeding risk. If it's for BMS, you use it for 1 month. If it's for drug-eluting stents, DAPT for 6 months. Remember, you have the option of reducing the DAPT even lower to less than 3 months. The intention being to reduce the bleeding risk. That is, if to reduce bleeding risk, you need to add a proton pump inhibitor. After 1 month, you can take off the aspirin, use ticagrelor alone, or shift to clopidogrel after 1 month. Special scenarios, elderly, low body weight, you use clopidogrel. In CVA, you avoid prasugrel. Patients on oral anticoagulants, ACS, triple therapy for the first month, and then afterwards you shift to clopidogrel alone. Before CABG, because of the pharmacology that I told you, you stop the P2Y12 inhibitors 5 days before surgery. In high-risk scenarios is the only reason you would add a GP2B3A into this mix, and in unconscious patients who can't take P2Y12 inhibitors, you add cangrelor. So this is basically exactly the recommendations which I read out to you. Primary prevention, class 1A indication for aspirin is only at intermediate risk, and at 10-year risk of cardiovascular disease more than. And this is the only class 1A indication for aspirin. Otherwise, all of it is 2B, 3A, whatever, but never a 1A indication in any other indication. So again, in TIA or stroke, DAPT is for 30 days, symptomatic intracranial stenosis, 90 days of DAPT, and carotid stenting, again, 90 days of DAPT. So basically, what you need to do is, beyond the time for treatment, this is almost the last slide, you need to assess cardiovascular risk and you need to assess bleeding risk. What do we have for that? We have the Hasbled scores. And so if you can use the scores effectively, you can prevent the bleeding. The whole idea of DAPT or modifying the DAPT or modifying and playing with the drugs is to reduce bleeding on a future event and recurrent events. So that's about all that I had to say. Thank you.
Thanks, Dr. Georgie, for giving us
Thank Dr. Georgie for his excellent lecture, and we thank all the other speakers for maintaining a good timeline throughout this discussion. Thank you so much for the wonderful session.
So we have Dr. Please, we can have 5 minutes. We have Dr. Peter Otasevic. Can you hear us? He is online.
Yes, hello,
from
Dr.
Belgrade.
Mittal.
So we can have a quick 5 minutes discussion before we end this session, and we can involve Dr. Peter.
right. So
Dr. Peter, is,
Yes, I'm here, so I can hear you. So I'm not sure if you can hear me.
easy.
Oh, yeah, I'm there. I'm on the screen. Great. Okay, so it's been a wonderful session, and it's been very enlightening for some of the lectures. So I really congratulate all the speakers for their good effort. So please continue with the questions if you have any.
yes, good. Thank you. Good morning. So anything you want?
So, any questions from the audience? Please, go ahead.
Therapy. Like, can you do aspirin and Plavix, or has to be?
Dr. Georgie, I think.
Yeah, he's here. Can you have
A high bleeding risk patient, even if it's a left main stent, it is a stent in a coronary artery. After the first month, if it's possibly with the newer stents, most of the newer stents can be on a single antiplatelet after the first 2 or 3 months. Preference is for ticagrelor or clopidogrel and not with aspirin.
Thank you.
Dr. Peter, any comment from your side?
No, not really. So please proceed.
Yeah.
any other question? Regarding the lipid management in ACS, the current status, and in India we are doing a trial in which from day one we are starting high intensity statin plus ezetimibe 10 plus bempedoic acid 180 milligram. And the trial showed that the attainment of LDL goal of less than 50 was much higher than using higher intensity alone. As Indians are at the most highest risk, and we develop disease a decade earlier than others. So this strategy is proving much more beneficial than using high intensity alone and subsequently not achieving the goal and adding. So instead of a sequential start of lipid lowering therapy, starting combination therapy from day one, so hitting hard, hitting early, proving much more beneficial than sequential.
Great. No, that's the now dictum that we have to reduce as fast and as much. Both the things are recommended.
But Dr. Brajesh, it's me.
Yeah.
See, the problem with the lipid management that we all have is we start we get an LDL below 1, we get an LDL below, it's total cholesterol below 100 or whatever. Once that is done, we have the smart physician who sees the patient afterwards and say, it's okay, you can stop your statins.
That depends on the level of understanding and knowledge, and that is why
So
we
which is
keep
wh-
conducting.
which is
we
why
keep conducting these kinds of seminars
meetings.
to infuse the knowledge in this.
Yes.
this
So
area.
the point is never stop this lipid management. Never ever stop. You are at a goal because the drug given has achieved that goal, and reducing the dose of the drug would take the cholesterol back up. So always keep the dose where you reach the the lipid level. Then I guess you would not change much in the risk management habits.
That's absolutely correct. Whatever the lipid lowering regime achieves the goal, that has to be continued. The moment you down titrate, it will bounce back. So that has to be maintained.
So just one
Any
quick-
other question?
So just one quick comment from my side. So when do you introduce PCSK9 inhibitors? At what point? Early after acute myocardial infarction or during the follow-up? So what's your practice?
After the triple combination oral therapy, if the patient is not at goal, it can be, or if the patient is able to afford, even with the double combination therapy, and you think the patient can achieve goal better and earlier, the PCSK9 is introduced. The problem is only of the cost. If the patient can afford, they can be incorporated in a regime much earlier.
So it depends on the reimbursement policy, right?
Yeah.
Thank you. Thank you. So I think we should end the session on this note. I will just felicitate Dr. P.K. Gupta and the session with well. Thank you, speakers and moderators. Thank you, Dr. Peter. I hope you can continue. And we can't give you plaque online. So next time when you are here, your plaque is.
I will be delighted to come. Sorry for not being able to join you in person this year, but hopefully I'll make it right next year.
Thank you. Thank you so much. With this, we move on to the next session. And once again, the time is the essence. Session number 2 is issues in cardiovascular disease. And I call upon session director, Dr. A. Srinivas Kumar. Every Indian cardiologist knows him very well. Dr. Srinivas Kumar is a legend in India in the interventional cardiology, especially now in the structural heart disease. And with this, I invite the chairpersons and moderators, Dr. Ajit Jain, Dr. Ghazi. Dr. Ajit Jain is a cardiac surgeon from New Delhi, India, and a wonderful friend, a very close friend of mine. Dr. Ghazi is my ex-colleague in Rashid Hospital, a senior professor, and I am very happy to have you, Dr. Ghazi, here. And we have one more surgeon, Dr. Samir Diwale from UAE. So please, the bench is all yours, and please carry on the proceedings. But please maintain the timings. That's my repeated request. Thank you.
Thank you, Dr. Mittal, sir, for your kind words of introduction. And we have interesting talks coming up in these issues in cardiovascular disease. And we have talks on heart failure and 2 important interventions which are happening in heart failure. And then we have an important lecture on lipid lowering, what we were discussing. Without further ado, we'll request our first speaker, Dr. Tahir Huzim, interventional cardiologist from Hurai, UAE, to deliver his talk on evolving landscape of heart failure management. What is new and what is next? I think as we all understand, the 4 pillars of heart failure therapy have significantly decreased the mortality in these heart failure patients. And let us listen more about it from Dr. Tahir. Over to you.
Well, thank you very much. Good morning, ladies and gentlemen. It's my great pleasure always to attend and participate in Shakeheart. I'm always attending this meeting, all the previous waves. So without further ado, because of short time, and to speak about the evolving landscape of heart failure management, what's new and what is next, it is a really tough task, but we'll try to make it as short as possible. Slides are moving. Sorry. So over the past 4 decades, we noticed that the heart failure patient have derived substantial benefit from major advances for the management of the heart failure. And this resulted in evolving treatment paradigm and new medication with novel mechanisms of action, as we see in the next slide. But unfortunately, with all these advances, still there are many unmet needs, particularly in the recent years. We notice that there is increase in the prevalence of the heart failure. This is probably explained by the aging population. We notice that there is an increase in the life expectancy of this population, probably because the patients survived more after acute myocardial infarction. After we saw from the previous presentation that there are a new medication for management of the patient with acute coronary syndrome and MI. So the patient now tend to live longer after myocardial infarction. So we started to see more heart failure cases. So if I want to just summarize the advances in the management of the heart failure in 2024, this is according to many data we received it. But if we look that in each step, and when we discuss the heart failure, there are many points that if you can tackle it, then you will prevent or even treat the patient with the heart failure. If we look to the pathophysiology of the heart failure, there are the main mechanisms of the heart failure, either myocardial injury or inflammation or autonomic nervous system dysregulation. So if you tackle any one of these pathophysiological points, you might prevent or even treat patients with the heart failure. And having said that most of the patients with heart failure, they will not come with heart failure alone. They will come with many comorbidities like obesity, chronic kidney disease, diabetes, iron deficiency. Again, if you tackle any one of these points, probably you can prevent or even you treat your patient with heart failure, probably to prevent the complication, improve the survival in this patient. The advances not only in the treatment, but the advances also involve the diagnosis and the use of AI now recently in the monitoring and managing this patient. Therapy, as mentioned by Dr. Srinivas, now not only all the 4 pillars, now the pillars become even more and more, and there are new data for managing this type of patient by even out of drugs. There are many intervention procedures to be done to improve this type of the patient. And the most probably new advances is how to monitor these patients at home. We have many patients with heart failure. No need to see them every time in the hospital, but you can monitor them in the home. So this is just to give you a summary of large number of randomized controlled trial to study the patient with the heart failure. If we look to this number of trials starting from 1986 to 2020, we see a huge number of the trials, a huge number of the patients enrolled to reach to the guidelines. And all of us as a cardiologist or even physician, till 2013, we have only limited options to treat patients with heart failure. We have that time only ACE or ARB plus beta blocker and MRI. Till 2014, when Army entered and changed the face of the treatment of the heart failure. When Paradigm Heart Failure studied the sacubitril valsartan, and it showed clearly that this drug play a major role in reducing primary composite 8-point, reducing cardiovascular death and heart failure hospitalization. In comparison, I mean, in comparison with the patient who is receiving enalapril, which was the best drug for treatment of heart failure at that time. So now sacubitril valsartan and Tristo, if we can just simplify from this trial, it can keep your patient with heart failure reduced ejection fraction out of the hospital and lives longer because it reduced the hospitalization, it reduced the mortality. The trial came more and more, and we noticed in the recent years that introduction of SGLT2 inhibitor, and now with these drugs, according to the recent guidelines, these drugs carry a class 1 recommendation in the treatment of the heart failure with reduced ejection fraction. Then later on, not only with heart failure reduced ejection fraction, even with heart failure with mildly reduced ejection fraction, and lastly with the heart failure with the preserved ejection fraction. So now we have the fantastic 4 drugs for treatment of the heart failure. Army, as proved by the heart failure, by Paradigm Heart Failure. The use of beta blockers since long time, we know that these drugs are very effective in treatment of the heart failure, MRA, and finally the SGLT2 inhibitor. But these are not only the drugs nowadays used for treatment of the heart failure, and these drugs should be started as early as possible. There are two protocols for using of them, either to use a gradual sequential protocol or rapid sequential protocol. So basically you can start the drugs gradually, then escalate the doses gradually. And these drugs, if you compare the 4 pillars of the heart failure with the conventional therapy before, ACE or ARB and beta blocker, we found that these 4 fantastic drugs reduce the cardiovascular mortality by 62%, reducing the death, cardiovascular death, reduce the heart failure hospitalization, cardiovascular death by 62%, reducing heart failure hospitalization 68%, and all-cause mortality 47%, and reduce the event-free survival by 44%. So these drugs really change the direction of the management of the heart failure once we started. And this drug to be used as soon as possible, because the benefit of this drug started early. Once you start early, you can prevent the further complication in the patient with the heart failure. So any delay in the initiation of these 4 drugs in eligible patient, unfortunately, lead to needless exposure to excess clinical risk. So this drug now clearly carry a strong indication to be used for all the patients with heart failure, particularly reduced ejection fraction and less contraindicated. But unfortunately, with these drugs, still there are some unmet needs to manage these patients with the heart failure. So there is another type of patient who come with the worsening of the heart failure, despite they are on using these 4 pillars of the heart failure, but they keep coming many times and admitted many times to the hospital because of what we call worsening heart failure. So the trial came what's called Victoria trial. So Victoria trial clearly proved that adding vericiguat improved both primary and secondary outcome in patients with the chronic and worsening heart failure, because it proved not only the hospitalization, but also improved the mortality. And the mechanism of the action of vericiguat, no need to go into details because of short time, but usually it increases the cyclic guanine cyclase and guanine monophosphate, and this gradually lead to decrease the stiffness, decrease the fibrosis, and improve in the cardiac function if you add it to the patient with the worsening heart failure. The guidelines later on came and proved in both American and European Society of Cardiology guidelines showed that adding vericiguat to the standard of care, which we call the 4 pillars, in the patient with worsening heart failure, it reduced the heart failure hospitalization and cardiovascular death, and it carried the 2B recommendation in both guidelines, European and American guidelines. Unfortunately, if we go to the patient with the heart failure, many of them, if you look to them, you will find they have iron deficiency. So iron deficiency, unfortunately, is an emerging problem in the patient with the chronic heart failure, affecting at least half of these patients. Now, because this problem and this comorbidity is very common in this type of the patient, there are many trials conducted, including FFIRM, heart failure, Iron Man, and Heart FID. And these trials conducted between 2022 to 2023. And with these trials, the guidelines changed to the level class 1A recommendation of intravenous iron supplementation is recommended in symptomatic patient with heart failure with reduced ejection fraction and heart failure with mild reduced ejection fraction and iron deficiency to alleviate the symptoms and improve the quality. So class 1 recommendation in heart failure with reduced ejection fraction to improve the symptoms and the quality of that. But also it carry class 2A recommendation to reduce hospitalization and even the mortality. So now adding another line of treatment for the patient with heart failure, managing of the managing of the iron deficiency, improve the outcome of this type of the patient. The guidelines clearly said, class 1 recommendation, any patient with heart failure, particularly heart failure with reduced ejection fraction, screening for the iron deficiency is recommended. Any patient admitted or seen in the outpatient with the heart failure, you have to screen them for the iron deficiency, because adding this drug to the standard of care improve the quality of life, improve the symptoms, and even improve the mortality. And when you give iron it should be given in the patient who have heart failure reduced ejection fraction with a serum ferritin less than 100, or if the serum ferritin between 100 and 299, but the TSAT less than 20%. These are the indication to give the iron in the patient with heart failure reduced ejection fraction. So now the guidelines changed from only 4 pillars to add another pillars. So the 4 pillars, ARNI, beta blocker, MRI, and SGLT2 inhibitor, these are class 1 recommendation. But if you add vericiguat for the patient with the heart failure and worsening condition, or the patient repeated admission, probably improve even the mortality. And if you add iron therapy for this patient, probably you will improve the symptoms, improve the quality of life, and later on even you reduce the mortality. And as we say that the comorbidities in the patient with heart failure are very common. Rarely we see the patient with heart failure alone. And most of the time we see this patient with a combination of chronic kidney disease, obesity, diabetes. So the recent trial came in the patient who have chronic kidney disease and diabetes, and they found that according to the fidelity pooled analysis, adding finerenone, which is non-steroidal MRA, improve the cardiovascular death and heart failure hospitalization, and improve even kidney outcome in this patient if added early. Again, one of the new drug added to the treatment of the patient with heart failure is omecamtiv. Omecamtiv, according to the Galactic Heart Failure, clearly say that greater effect of this drug on the primary composite outcome of the first heart failure event or even cardiovascular death if it started in the patient with the heart failure. So in conclusion, instead of 4 pillars, now we have 7 pillars in the management of the heart failure. So we need beta blocker, we need ARNI, we need aldosterone antagonism, we need neprilysin inhibitor, we need SGLT2 inhibitor, we need also omecamtiv, and we need also very sick, particularly for the patient with heart failure, worsening heart failure. But unfortunately, with all these drugs, 7, 4, 6, or 5 pillars, still there are unmet needs. So do we need another treatment to probably improve the mortality of this patient? Yes, I need only 1 minute. So there are adding anti-inflammatory medication, and there are many trials, as mentioned, that have even improved the mortality and the cardiovascular outcome. If we look to this study, it's called HERB study, they are using drugs called zetribicumab, and they compared it with the placebo, and they found that this drug even reduced the mortality and cardiovascular event. Other modalities in the management of the heart failure is not only medication, but adding a procedure like transcatheter edge-to-edge mitral valve repair, or putting a sensor to monitor this type of the patient to have proper management. This is about the heart failure with the reduced ejection fraction. Now about heart failure with the preserved ejection fraction, the data about SGLT2 inhibitor as a class 1 recommendation. But recently, finerenone, if added in the patient who have diabetes, particularly in the heart failure with the preserved ejection fraction, they can reduce symptoms and even improve the cardiovascular outcome. And finally, tirzepatide, which is Mounjaro, if used in patient who is obese and heart failure with the preserved ejection fraction, also it showed a promising improvement in the cardiovascular outcome if added early in the treatment. Thank you very much.
Thank you, doctor, for rapidly covering all the newer drugs along with the established 4 pillars. I request co-chair to introduce next speaker.
Next lecture is basically online by Dr. Praveen Chandra. He is the chairman of interventional cardiology at Medanta Hospital, New Delhi, and one of the pioneer cardiologists who started Tower. And
hello and good morning to all of you. It is a pleasure to be back again to this very I must say, close to the heart endeavor of my friend Dr. Brajesh Mittal, who has initiated this program and is running so well. But unfortunately, I cannot be there in person. However, I would like to share my views and our experience of structural heart interventions beyond TAVR. So in the next 10 minutes or so, I am going to share with you the various structural heart interventions which we are presently doing and what are the outcomes in these patients. So the structural interventions started with aortic interventions, which is the TAVR for severe aortic stenosis and for aortic valve-in-valve diseases. But now we are also doing the mitral valve, which is the mitral clip treatment, the mitral annulus calcification, TMVR, and TMVIV, which is transcatheter mitral valve-in-valve replacement. Along with this, we also sometimes have to treat the tricuspid valve for severe tricuspid regurgitation by doing tricuspid clip or a tric valve implantation, and pulmonary valve replacement in patients who are post-surgical patients where a previous surgery has been done for either TOF or other congenital heart diseases, and now the pulmonary valve is either leaking or has become stenotic. Then post-surgical patients who have previous mitral or aortic valve surgery done and are now having paravalvular leakages are also being treated with interventional techniques where we put a plug known as the paravalvular leak closures. And then finally, the Watchman device or the amulet device for closure of the left atrial appendage for prevention of stroke. So these are the scope of my presentation today. And so first of all, we'll go to the transcatheter mitral valve treatment. As I said already, it is valve in valve, valve in MAC, valve in ring, MitraClip, and PVL closure, as you are seeing here. And all this is done through a transseptal approach. So we don't have to go transapical. 99.9% everything is transfemoral vein and going through the transseptal approach. So those patients who have prosthetic valve dysfunction, where the valve regurgitation is happening or sometimes even stenosis, in these patients we can do this transcatheter mitral valve and valve implantation, and is very successful. We have done more than 250-300 procedures in the last so many years, and I can tell you the very next day the patient can be discharged because it is a transvenous procedure. And that is how you can see that so many patients are coming up because they have received a valve replacement in the past 10 years, 12 years, because usually the prosthetic valves start degenerating beyond 10 years. Average, and then up to 15 years. So they are in that range from the post-surgical situation. The in-hospital mortality is very low when we do transcatheter mitral valve replacement. But if we do surgery, as you can see here, with every surgery, the operative mortality goes up. So that is why our preferred treatment today for a prosthetic heart valve dysfunction with a previous surgery is transcatheter mitral valve replacement. Then, as you can see here in this database of 5-year outcomes, also shows very low incidence of complications like stroke, etc. And these patients we take up by knowing what exactly is the valve. So here you can see these are the various type of valve. We know fluoroscopically also which valve was done, and based on that we decide which size of the transcatheter valve we have to use. So this is how it looks in the the cath lab. We first do the septal puncture, then we dilate the septum by this balloon, as you can see here, and then we take the wire to cross this previous surgically implanted valve, and this is the way it is implanted inside the previous surgical valve, and immediately the valve starts functioning and everything stays very well. As you can see here, this is looking quite good on the transesophageal echo, and then at the same time in some patients we can even close the defect which we have created through which we have taken the valve inside, can also be closed with a atrial septal closure device, but most of the times today we leave it like that because it heals on its own. Then the second important investigation is second important treatment which we do today is a valve in MAC, which means mitral annular calcification. This is a young patient who was having severe calcified mitral stenosis. The valve surgery was denied because this patient had MAC, and surgeon said that it will be very high risk. So we did a CT scan. CT scan is the most important investigation to see how much is the calcification. If the calcification is like more than 270 degrees, as you see here on the CT scan, this patient is a reasonably good candidate for a valve in MAC treatment. And here you see that we have replaced this valve without any surgery, and this is the prosthetic valve which was done through transcatheter approach, and we got very good result. Then valve and ring cases where a surgery has been done earlier with a ring repair of the mitral valve. Here you can see it was on CT. So CT is the most important test which we have to do, a CT angiogram, to know what exactly will be the anatomy inside, how do we size the valve, and whether there is any risk of having obstruction to the left ventricle or not. So here you see that we are replacing this valve transcatheter through a valve and ring, It is the ring which was done surgically earlier. And in these cases also it is very easy, very quick, and the patients can be discharged the very next day. So here you see that this is a patient where two valves have been done. One was the aortic and the second was the valve ring. Then in some patients, if there is a risk of obstruction, we do a new technique known as lampoon technique, where what we do is we slice the anterior mitral leaflet before we put the valve. So this is slicing the anterior mitral leaflet through a transcatheter approach through electrosurgery. This takes about half an hour or so, and after that we replace the valve through a transcatheter approach. So this is the CT analysis, which is very important in these cases, which we do. And once it is all done, then we go ahead and do this treatment. So this patient had a very high risk of an LVOT obstruction after the valve, which was predicted. So here we are doing this lampoon technique, where a wire is electrified and we cut through the anterior mitral leaflet in this patient, which we could achieve very easily. And after that, we replace the valve. So here you can see that the valve is being implanted in this case after the lampoon has been done. So these are the steps for this valve in valve. And once the patient is okay, we shift him out and discharge the very next day. So the aortic, as you can see that the valve functioning was very good. The gradient was only 6. There was no MR, no PVR. Sometimes patients also have double valve replacements and both the valves are now degenerated and the anatomy is very, very distorted. Second surgery cannot be done now. As you can see on this transesophageal echo, the LA was so distorted, the risk of surgery was very high, 56%. So that is why we did a CT scan to assess the sizes, to assess the feasibility. And once that was done, reconfirmation of the valve sizes, we took this patient up. These were the two valves which were earlier operated. And after that, we replaced these two valves through a transcatheter approach, as you see in these diagrams. And once planning was done, we took my valve, which was the balloon expandable valve. And here you can see that the valve is replaced very successfully in both these locations. And thereafter, the patient did very well. After that, only aspirin therapy was being given. No anticoagulation further was required. Similarly, for tricuspid valve, now we are treating them by using clips, and the same clip as we use for mitral clip, same clip is used to treat the severe tricuspid regurgitation. Those patients who cannot be operated for tricuspid valve regurgitation, who already have a previous surgery done for other valves, these patients, now we do tricuspid clipping treatment, which you can see here. This is how it is done. It is done through a help of a transesophageal echo. And these are the findings which we look at. The septal leaflet length, the tethering of the leaflets, the coaptation gap, and the, if there is a presence of a ventricular lead or not. So based on all that, we take a decision. So like, in this case, this was a patient who was waiting for a liver transplant, but surgery was not being done because she had severe tricuspid regurgitation, as you can see here on this echo. So we did the tricuspid clipping here. This is the tricuspid clip through a transesophageal echo guidance. We are doing it, and you can see that the clip has been put here, and the leakage has become very, very reduced, minimal. And within 1 week of this treatment, patient underwent a liver transplant surgery successfully and is doing very well. Then we have some patients who have paravalvular leaks, as in this patient who was an elderly patient. Previous surgery was done, and now the valve was leaking from the side, from the suturing ring, from the side of that it was leaking. So we treated that, and then also treated his tricuspid regurgitation by putting these two valves in the tricuspid position. This is known as the tricuspid trick valve, which is done successfully in this case after the PVL closure. So he received PVL closure, and these are the two valves. This is the SVC valve, superior vena cava valve, and this is the inferior vena cava valve, as you can see here. This is the second valve which is being implanted, superior vena cava, inferior vena cava, and the patient's tricuspid regurgitation became much lesser. So finally, for mitral valve, for leaking mitral valves, now the very important treatment both for degenerative and functional regurgitation, we can now do mitral clip where surgery cannot be done. So it is a transcatheter approach. Patients stay in the hospital for about 24 to 48 hours, and usually they can go home without any anticoagulation, only aspirin therapy for 3 months. So this is the device which we use. It is again a catheter-based device and is very successfully being done worldwide. So severe eccentric MR in this patient was treated with a clip, and here you can see that the clip is in position, and after the clip, once we exactly assess whether the clip position is good or not, then we release the clip. So the clip looks like this on fluoroscopic examination. Then paravalvular leak again, as you can see here, this is a patient where there were 2 leaks, and we treated both these leaks through the transcatheter approach, and this is how it looks on the transesophageal echo. As you can see here, the device looks like this. So these are, in this patient, we had to put 2 or 3, these plugs, but otherwise, and patient did very well after that, and the regurgitation reduced significantly. And transesophageal echo again is a very important check for this. So with this, I come to the end of my presentation. And in our center, we are one of the very, aggressive structural heart intervention center in India. And we have done nearly about 1,500 cases. And amongst them, TAVR is the biggest number, followed by TMVR, tricuspid valve replacement, mitral clip, and P-valve closure devices. So with this, I thank you all for listening to this presentation, and I hope the conference a big success.
Hello.
Thank you, Dr. Pawan Chandra, for covering up all the important aspects. I'm Dr. Srinivas Kumar here. Thanks for introducing me to Dr. Brijesh. And any questions or comments from the hall, because Praveen may not stay further. If you have any questions, he can answer before he leaves. Yeah, Dr. Brijesh is coming to ask you a question. Hope you can hear us.
Yes, I can. Very well.
Well, so I'm here to ask you a question. Next year, are you coming? This is the question.
Of course. 100%. I'm booking myself now. Please invite me.
Okay. Just to give a background to the audience, that my first conference, which was done in 2015, and Praveen Chandra was there in person, and then 2016 and 17. So he has been with us in person for such a long time. So we are really missing you, and next year we hope to see you in person. Thank you so much.
Thank you very much.
Thank you. Thank you. Please carry on.
Next presentation is by Dr. A. Srinivas Kumar. He is the chairman at Cardiac Sciences Apollo Hospital, Hyderabad, going to deliver a talk on the TAVR. Dr. Srinivas.
Yeah, good morning, friends, and thank you, Dr. Mittal, for the opportunity again. And Dubai is a beautiful place. I love to come to this place, and I'm also thanking Praveen Chandra for making me introduced to Dr. Mittal. And what I was wanting to speak is on this important newer procedure which has come up, that is the TAVR. All the structural interventions, you heard it, Dr. Praveen Chandra speak on it, but TAVR is already a step ahead. That is has proved itself, and then probably it is one of the best technique which saves a lot of sick patients. So I'll briefly cover up how it evolved and what is the present status and where is it going to be in future. This slide brings best wishes from Apollo Group of Hospitals, where we are trying to network across Apollos, collect the data, be it PCI or the TAVR, and combinedly we can do great jobs, and then that's how we want. But the problems are we all don't come together, but it's always trying to be together. We should pay our respects to this great man, Professor Alan Tribia. He pioneered this technique. In 2002, a sick patient who is about to die, he did this procedure in not in the regular procedure approach what we do, but in a transeptal fashion. And patient dramatically improved within 15 minutes. And that's how he initially mentioned that he himself did not think that this technique could evolve so well and save so many lives. At a personal level, I would be thankful. I think, can I have a pointer? So So this is Dr. Martin Leon and Dr. Sushil Kodali standing there. The first fax and heart team approach, we had tie-up with them. That's how they helped us establishing this. And Dr. Sushil Kodali, the good friend of mine, can the pointer work? He is the one, and he actually helped us initially to come in about 2000. 5 years back before COVID times, and we did procedures together. In our part of country, there had some challenges in tower, but once we did about 40, 50 towers without much of a complication, then the procedures got established. Now, I think most of the centers, it is being done successfully. And we're extremely thankful to this collaboration for improving it further. We did some of the intricacies in Italy, Amsterdam. They were aggressively doing towers and coronary arteries together. And this Swiss Heart Center, I particularly would like to show always as a simulate model where both cardiologists and cardiac surgeons sit together in the evening and discuss which patient goes for SAVR, which patient goes for TAVR. It's a model to emulate. And then further, this is Cleveland Clinic. That Samir Kapad, a good friend, now is chairing that Cleveland Clinic. Then we had opportunity to learn single femoral artery technique, and this Cleveland University, how to decrease this complication rate of complete heart block. That Atizani is pioneering this cusp overlap technique. We had learned some of these intricacies of this new procedure so that we are very comfortable now. Extremely thankful to all the colleagues across the country who sent patients for TAVR to Apollo, and Apollo was in news. We did 5 towers together. That's how the management became happy, and then probably established the new setups like hybrid cath lab, which helps in the initial part of our program to do these procedures more comfortably and successfully. Back to the topic per se, as the population is growing in India too, we have elderly people. By 2040, the number of procedures are supposed to increase further. And in US, the 75% of aortic valve procedures done are by towers. And so that's the way it is exploding in US. And in India, we have not reached that stage. I think not even 10% of aortic valve procedures are done through tower, but we're about to reach there. What is also happening is that this procedures are being done more in younger patients, but we should follow the guidelines and do what is the best. What does the guidelines say? Initially, the heart team approach, again, is proven well established as a very important aspect in deciding which patients goes to TAVR and SAVR. Initially, in high risk, prohibitively high risk patients, anyway, you have no choice. Patients do well, subjected for the TAVR procedures, but later on, even in the low risk trials, now the age becomes an important criteria. The ACC-AHA recommends this for more than 65. And then probably the European Society recommends for more than 75. This is keeping in view these valve processes which will last for about a decade after it's implanted. That's very important to keep in mind how much time the patient is likely to survive after the procedure. Then we have many interventional cardiology procedures, but TAVR is proven beyond doubt, and it's one of the rare procedures which outcomes after the procedure improved 3 times the mortality compared to the standard therapies. Very few procedures improve outcomes and decrease mortality so much like this. And then not only the quantity of mortality per se, but the quality of life improves tremendously after these procedures. We have seen patients who are sick on IV infusions going to play tennis and going to vote. That's a beauty of these procedures. Initially, the partner trial showed that it has to be equivalent to surgery, which it did. Then later on, it went on to prove core valves, went on to prove it superior to surgery. Then, so 2025, no one could have predicted that so much rapid evolution of technology happens, and that's how the minimalistic strategy. We don't give general anesthesia. We do most of it is conscious sedation, no TE now, by and large, and minimal ICU stays. Most of the patients are discharged in 1 to 2 days. In COVID times, we were discharging the patient next day morning itself. That's how it's revolutionized the therapy of the sick aortic stenosis patients. To recapitulate how it has happened, we should give a lot of credit to Martin Leon and the partner trial groups, keeping what is good for the patients apart from all the heart team members. What is important is to keep what is good for the patients. With this approach, I think we have come a long way in decreasing 30-day mortality from 6.3% before to less than 1.4. So that has been done through systematic approach of taking through. Many of you must be wondering what is this partner. Displacement of aortic valve, transcatheter valve. It's mnemonic for that. Partner 1 in high-risk patients, anyway high-risk for surgery, not suitable, it did benefit. Partner 2A, again, moderate risk patients, it showed it benefit. 2B is comparison of different type of valves, again, it showed to be superior. The main important thing happened, the game changer is Partner 3 trial. Partner 3 trial basically is done in low-risk patients, which are surgically suitable. Our surgical colleagues do a good job, so we need to be careful and deliver the goods equally well. Why we are interested is 80% of aortic stenosis patients fall into this category of low risk. The Partner 3 is a randomized trial, 1,000 in each arms were TAVR versus surgery were studied carefully. And again, it showed death, stroke, rehospitalization, not only equal, but it is proven slightly superior to surgical technique. And that's how it proved its superiority. All strokes were less, death and disabling strokes were less. And if you see any of the endpoint, any of the age subgroup, any subgroup of patients, whatever functional class it is, they all benefited. Some of these endpoints like atrial fibrillation, bleeding, length of hospitalization, all that would be definitely less with TAVR, agreed. But bleedings, the vascular complications and pacemaker rates are only slightly high with TAVR. If you are now asked in today after Partner 3 trial, surgery performs better in valve leakages and less of pacemakers. Sometimes it is equivalent, but TAVR is better in most of the things which are mentioned on the right. Mortality, strokes, hospitalizations, lot of other advantages. So it is very simple for us to choose which therapy is better. So that's how the Partner 3 trial establishes in low risk patients. We have 5 years outcomes also showed that the advantages which are at 1 year continue to persist even at 5 years, be it strokes, decreasing endpoints. Slight increase in valve thrombosis was noted, but the good thing is once they were anticoagulated well, many of them, the valve functions improved. So the mean gradients and valve areas were maintained up to 5 years, and that's a regurgitation for not much, and quality of life, the procedure is durable up to 5 years. So that's how it is a Partner 5-year trial showed that both therapies are comparable. Then we see this, mortalities have significantly reduced from 24% to 1%. So this got published in NEJM, and case example of balloon expandable valves. For sake of time, I need to rush, I think. I wanted to show 1 or 2 case examples. This is a sentinel device which is placed to prevent the strokes. Then we take the valve in, then we place it according to the position and then inflate it. This valve, balloon expandable valves work just like stents. You take there and inflate it, and once it is done, then remove everything. There won't be any palaver leaks and the gradients, and the sentinel device is removed immediately, and femoral arteries need to be checked carefully to avoid complications. And that's how this therapy has evolutionized, because it works like stents and easy to implant and behaves like surgical prosthesis. And the Evolute front self-expanding valves are also doing well. Initially, the 1-year trials were better, and then now we recently have 4 years and 5 years follow-up also with self-expanding valves, showing that this valve also behaves well with very good valve hemodynamics with valve areas. That is a low 4 years results, and then probably 5-year results were recently done in ACC 2025. So in today, the TAVR journey is improved significantly, and patients do well and get discharged the next day. The most important is the CT analysis. This is the case example of a self-expanding valve, again, similar front. And then some advantages for each of it. 80% of the procedures could be done by either of the valves, but some, say, in smaller annulus, probably self-expanding as a role. Echo has its place in the lab again to check the positions and check the gradients, and they need to be done well. Then people said that it is all the company-sponsored trials. Then we came with a new trial called Dedicate trial, which is non-sponsored, with any type of TAVR valve could be compared with SAVR. Even in that, it showed that fatal strokes, deaths are significantly less with TAVR. Indian company, MyValve, also came out with this data where this MyValve was compared with all the other valves like balloon expandable valves. So the compared TAVI-1 trial again was presented a recent PCR, showed that it works well. So TAVR indications, not only in high risk, even moderate and low risk patients, we do use this, but we need to exceed our discretion and use it in appropriate patients. If young patients ask, you should tell them what is correct heart team wise. So less than 50 years, patient goes for TAVR. more than 75 years, they go for TAVR. In between, we need to execute decision-making analysis and give what is best. Low-risk patients, they don't want any complications to happen. We need to keep this after 9 to 10 years, valve could degenerate. That's why we should use it appropriately. Long-term results are there. There are some advancements happening in surgical fronts through Resilia. These are the 5 golden rules of TAVR. All this applies to transfemoral TAVR, and we need to give good results to these patients. Eugene Braunwald mentioned that it's a historic movement, and himself said that this therapy works well. Now, one word, 1 minute about what is happening in the Indian front. We started collecting data in NIC when I was chairman. Now we do about 1,700 to 2,000 TAVRs in a month. This has been our experience in Apollo, about 150 plus patients. TAVRs done, most of them are elderly, high-risk patients, and we have reasonable good success. And LBVPs is which bothers post-procedure, but they're quite safe with not many requiring pacemaker implants. Most of the Indian patients have this bicuspid valve anatomy, unlike West, and these patients do well. So that's, ladies and gentlemen, in 2025, what we want is we do not bother whether the patient is high risk or low risk for surgery. We have to see which patient does well with TAVR. Are there any particular contraindications like low coronary heights or heavy calcium where they may not do well, where our surgical colleagues might do? We have done TAVRs in all these high risk subsets which are mentioned here. For sake of time, I can't show all of that, but TAVR works. And patients and physicians, we want less invasive therapy. And but we need to keep the patient's age in mind and do what is best for the patients. I think the valve therapies are here to stay. As durable and low profile valves come, we start doing this in all these concomitant disease patients. And now we have gone a step ahead with moderate aortic stenosis, and then probably we are about to go into aortic regurgitation therapy too. And Martin Leon proposed this concept of leaflet modification. This is a CGL revolutionary system, which is actually 8 French goes through that, and the newer technologies are coming up where the French size decreases and the complications could decrease further. Early TAVR and Avatar, both, why wait till the patients develop severe LV dysfunctions or symptomatic? In the moderate aortic stenosis patients are asymptomatic patients also people started doing. Cardiologists are smart, but we need to be keeping in view what is good for the patients. This Avatar and early TAVR showed both are patients with asymptomatic also do well and decrease hospitalizations. That's what it showed. And the time to conversion to AVR in patients to wait till they become symptomatic, I'm finishing, then it did well. So we are again TAVR unload in LV dysfunction patients is done, and then JenaValve system is for aortic regurgitation, where even in symptomatic aortic regurgitation patients, then this new system of JenaValve we started implanting in AR patients, and then we have 2-year follow-up. Now we are on the phase of ARTIST trial. How PARTNER was done for AS, we are going to the stage where to randomize with this valve severe AR patients, and hopefully the results will come positive. Some of these novel leaflet modification technologies which are coming up, why wait to develop severe AS? We can prevent it happening, it's good. Why we struggle to do all this is basically we want our patients to do well. Happy patients. This was a sick patient which I said went to vote from Nagpur. The patient came and patients immediately improved dramatically. More about it will be discussed in upcoming TCT India meeting. Request all of you to block your dates and be there. And Dr. Brijesh Mittal and others will be there. Thank you again for the opportunity.
Thank you, Dr. Srinivas. Now session is open for the questions. Please.
There's one more talk in the session. After that, we'll have whatever it is.
One more session of this, one more lecture of this session by Dr. Sunil Modi. He is the Senior Consultant Interventional Cardiologist at Indraprastha Apollo Hospital, Delhi. Dr. Sunil, please.
Change from here. Okay. Thank you very much, Dr. Srinivas, my colleagues here. Thanks, Dr. Brijesh Mittal, for making it possible to be here and interact with all of you. In past, okay. Yeah, yes. 125 years, the data is there since 1900. It was only 1 year out of 125 years that cardiovascular disease was not the number one cause. Otherwise, all 124 years, it continued to be number one reason for mortality in human beings. And I'm sure this is not a quiz. Just to remind you, it was only 1918 flu pandemic, not this recent COVID, not World War II, not World War I. It was only 1918 that cardiovascular mortality fell number two. Just to remind that what we are talking is extremely important as far as the human morbidity mortality is concerned. Now, in spite of all the advances which we have seen over the last 2 or 3 decades, the heart disease and particularly coronary heart disease continues to be number one killer of the mankind. Now, just to give you the data, about 12 million deaths annually worldwide. Most of the victims, more than half of the victims who die of heart attacks will not see the face of the physician. They will not reach the hospital. Bad statistics. Half of the men and 2/3 of the women who died suddenly of heart attacks had no previous symptoms of the disease. So they didn't know till the day they died that they have heart disease. It's a conspiracy of close cousins. All of us know diabetes, hypertension, lipids, tobacco habits, so on and so forth. But out of all these, Interheart Studies has told us very clearly that most important contributor to the risk of heart disease are the lipids, abnormal lipids. So lipid lowering will attract all the attention, will continue to be one of the most important, the management and prevention of the heart diseases. So lipid lowering, why, when, how much, how fast, how long is probably what I am going to cover in next 8 or 9 minutes. No absolute disclosure. Why? Why do we want to lower the lipids? There is plenty of evidence over the last 2 decades that LDL reduction regresses the plaque. It actually reverses the atherosclerotic plaque, regresses, reduce the atheroma volume in well-controlled IVUS studies. So there is no doubt left in anybody's mind, which used to be there two decades ago, that whether heart disease can be reversed or not, except that Dr. Ornish believed it, but we all didn't believe till 2 decades, 3 decades ago. But now there is plenty of evidence through steroid, Roma, glove trial, just to give you to remember the reversal trial, which showed that it is possible to reverse the atheroma volume, and particularly now PCSK9 trials, GLAGO trials showed that you can actually reverse the atheroma and bring it to the non-critical values. So once we can reverse the atheroma, there is again plenty of clinical evidence that you reduce the LDL and you reduce the morbidity and mortality of heart disease. So lowering of LDL has a direct 1:1 relationship with the risk of the coronary heart disease. It has been tested for both secondary prevention as well as for the primary prevention. So both secondary prevention and primary prevention trials have shown that you lower the LDL and you gain the benefit of coronary heart disease mortality and morbidity. Which patients in whom we should give lipid lowering? Statins trial have clearly told us that statins or lowering lipid reduce the incidence of coronary events in patients with all kind of levels of cholesterol, both with or without known heart disease. So any level of cholesterol, whether patient has a coronary disease or not, in all kind of patients, further lowering lipid or lowering LDL is going to help. So, and whether patient is diabetic, hypertensive, smoker, elderly, women, men, any group of patients will receive the benefit of lipid lowering. How should we do it? Now we all know we have been tuned to statins for over 2 or 3 decades now. Statins save lives, events, money. Statins work on almost everyone. High dose statins are often required to obtain the optimal benefits. We grossly underuse statins, not anymore now. I think particularly last 1 decade has increased the use of statins quite a bit. And also remember the nocebo effect. People who come with lot of symptoms after a statin, you tell them that I'm not using this statin for cholesterol, I'm using this statin to save your heart attack, to save your sudden death, to save need for angioplasty and bypass surgery. And next time when they come, they don't have any symptoms. So, a lot of role of what we call as nocebo effect. just because they take the medicines, they get the symptom, and systems are required to streamline the statin use. Now, of course, statin will continue to be the most important drug, but then there are plenty of other newer drugs which we have to just mention the names with the short of time: ezetimibe, bempedoic acid, PCSK9 inhibitors, inclisiran. We have now oral PCSK9 inhibitor, and the trials are already completed, and most likely by next year it should be in the pipeline. And some is CETP inhibitors, or citrapips, which have shown the results. We know the ezetimibe statin combination works. It works very well, and almost most of the patients now after ACS receive the combination of statin and ezetimibe. Bempedoic acid is basically trials are done in statin intolerant patients. The patients either they are not really tolerating statins or they are not willing to take statins. There are many patients who will tolerate statins, but they don't want a statin because some of their relations, some of their friends have got severe symptoms with relations, so they do not want, although they are tolerant. So in such people, bempedoic acid trial has shown the benefits. So bempedoic acid along with ezetimibe both has also worked better than individual drug alone. PCSK9 inhibitor is a complete class in itself, and it is very convincingly told us that lower is the LDL, more is the benefit. So on average, drop of LDL by 59% has reduced the MACE by further 15 to 25%. So first time these trials by PCSK9 inhibitors have convinced us that you can go further lower than 40, 30, 25, even up to 15 to keep on achieving more and more benefits with the LDL lowering. Inclisiran again is a topic in itself, twice a year, injectable, has shown very good results. And I think we will be getting more and more data in next 1 or 2 years of the outcome data, and will be one of the very important drug to be used. More like vaccines, you just take 2 vaccines in a year and you get rid of the atherosclerotic progression. So I think the acceptance of this drug is going to increase if it shows very positive outcome data. I'm sure this will be, and of course, cost factor will also take care of itself, as many drugs have shown that the cost has taken care. Oral PCSK9 inhibitor, as I just told you, is in the pipeline, and very soon we'll be using it. The Brooklyn trial has shown in the recent AHA 2025 that it significantly reduced LDL, particularly in patients of heterozygous familial hypercholesteremia who are not able to attain LDL targets, and with the available lipid lowering therapies. Now, I'm not going into details of further many drugs which are being tried to lower the lipids, and they are likely to be successful in next this thing. Triglycerides, as all of you know, the icosapentalethyl has shown clearly the positive results in REDUCE-IT trial, and has been recommended in those patients who have not attained the ideal targets or their triglycerides are above 130, as this trial included all the patients whose triglycerides were above 130 to attain more benefit, further benefit, over and above the benefit which other drugs have already given. You reduce the chances of MI and cardiac death, stroke, and need for revascularization. Now, again, LP-little-a is in a topic in itself. I thought somebody is going to speak on LP-little-a in this meeting, but I just reviewed the program. It's not there. So remember now, this is going to be the lipid of next decade. As we are learning more and more, we have already learned quite a bit. It will be more interesting in next decade because there are some dedicated drugs which are being tried now. Not the current lipid lowering drugs, but the other dedicated molecules which are being tried to reduce LP-little-a with very expectedly very significant benefit of the mortality and morbidity. Now, how much should we lower is always a good discussion. Till date, all the trials have told us that the lower is better. Now, lower is better was already shown by many trials in the past, but then PCSK9 trials further showed us that it can be further better if we lower. So there is a combined evidence of 33% relative risk reduction by further lowering the. Now, these trials in the past, TNT and Prove It, TME2 trials have shown that as you go in the lower range of LDL, even lower than 40, 30, 20, you are likely to get more benefit of the risk reduction without having more side effects. And all these trial which brought down the LDL below 40 have not shown any extra or significant side effects as compared to the placebo. So it is quite safe to lower it down to those levels which were not even, thinkable some few years ago. So how low is it low LDL? Meta-analysis of 3 non-statin trials over and above statin when they used ezetimibe, PCSK9, showed that consistent relative risk reduction in major vascular events when LDL was reduced from average of 61 to 21 even with no offsetting adverse effects. How long we should use? You should continue using just like you use seat belt and helmet throughout the life you drive. So relative risk reduction increases as the duration of treatment lengthens. There are trials to show that longer you use, more is the benefit. How soon after ACS? Definitely shown that as soon as possible after ACS, maybe on the first day, why not? So all the ACS trials have shown the benefit of lowering LDL right from the day one. Now, just 2 small concepts of mine, if I might exceed for half a minute. The atherosclerosis begins in childhood. The first case which Dr. Mittal showed you, LDL 250 on the day of arrival with ACS. I mean, this is ridiculous. You are diagnosing pregnancy when the lady has already ejected out the baby. You don't diagnose pregnancy on the day of delivery. So 260 LDL knowing on the day of angioplasty is something like that. So the care should begin from very beginning. 1 out of 250 people are born with familial heterozygous familial hypercholesteremia. 1 out of 250. Delhi has a population of 2.5 crores. So in Delhi itself, 1 lakh people are moving around without knowing that they have LDL above 190 or 200. Why these people will not have MI at the age of 20, 25, 30? Why will MI wait till age of 50 or 60? I mean, it looks very ridiculous to me that you are allowing 1 people to die prematurely without letting them know that they have such a high risk factor. So in my thinking, and then there is plenty of data of treating familial hypercholesteremia to the extent that lead number 3, statin therapy alone could potentially avert 96 to 98% of familial hypercholesteremia related coronary deaths in individuals below 40 years of age. So first MI is not a disease of elderly age. All of our colleague friends, this singer Mukesh and so many actors have died below 50 years of age. And as I say, death is inevitable, we know, but premature deaths should not be accepted. Coronary heart disease is a preventable disease. Just give me 30 seconds more. Primary prevention, secondary prevention. Remember, do not forget that acute MI and sudden cardiac death is the first event in 2/3 of the patients of CAD. So 2 out of 3 people do not have a second inning to play. There is no secondary prevention in 2 out of 3. Secondary prevention is only 1 out of 3. So all patients with high risk factor should be treated like secondary prevention, even if they have not received any attention so far. So waiting for chest pain to initiate therapy in patients of coronary risk factor is just like waiting for labor pain. So identify high risk patients and start treating them to prevent heart attacks. Wisdom lies not in the amount of knowledge acquired, but in the degree of its application. In the last slide, this is the Christian Bernard, who was the first heart transplant surgeon. He has said, I have saved the lives of 150 people by heart transplants. If I had focused on preventive medicine earlier, I might have saved 150 million lives. Thank you very much.
Thank you, Dr. Modi, for highlighting this importance of statin therapy very early and aggressive statin to lower. The lowest is the best. I think you can present the memento. We have Dr. Samir Diwale, surgeon, with us. It's been quiet. You want to have any comments before we close, sir?
Thank you, all the speakers, and Dr. Brijesh. What a wonderful session. Very interesting for cardiac surgeons to be invited to such meetings because it opens our eyes on what is happening in the field of interventional cardiology, especially structural heart disease. And I am very happy to see the kind of work which is going on, the two presentations, as well as the preventive aspect and the, how to fix structural heart disease. I have just a couple of comments on this. And I would like to discuss this with you, Dr. Srinivas. Dr. Srinivas and I have been colleagues in the past. He is a wonderful cardiologist, one of the best I have seen. And I would like to ask you, what are the challenges in a small aortic root? This is something which cardiac surgeons face many times, especially in our population. Young patients, 50 kilos, and aortic root is very small.
That's an important aspect. Surgeons also are worried because root enlargement and all that is not easy to be done. So in that subset of patients, self-expanding valves with a better UAS, and because annulus and the valve is supraannular there,
Right.
you need to have better. So it's need to be performing slightly better over the balloon expandable valves. So even the small annulus, many of the surgeons, 19 mm valves, 20 mm valves, it is actually a disservice. If you can send them for patients for TAVR with better gradients, there might be, there's no randomized direct comparison between surgery versus TAVR in the small annulus, but balloon expandable versus self-expandable valve comparison has come with a smart TAVR trial showed that self-expanding valves with better valve areas and less gradients are doing better in a small annulus patient.
That is good to know.
Yeah.
What's the minimum size of annulus where you are going to do TAVR and when you are going to say no, TAVR is not possible?
No, generally, what we have seen is 19 mm. We are doing TAVRs in that. So the age is more important than the annulus for us because if a patient comes very young, then probably valves tend to degenerate. So we don't want to do TAVR procedures in less than 65 years of age because as of now, we have data with TAVR valves for 10 years. So if the patient is likely to survive for more than 10 years after the procedure, then we need to keep that in mind. Though we can perform TAVR in TAVR or TAVR, that the life journey of a patient need to be planned depending upon the age of the patient. That's why the recommendation is more than 65 years of age only we perform. Sir, 5 minutes, we'll ask the delegates to ask any questions because...
Any quick questions? We have only 2-3 minutes.
Yeah, heart failure.
There are many questions, basically. Yeah. So before that, I would just like to give the memento to our moderators, and then you can continue discussion for a few minutes, and then we'll break for the morning session of morning tea. Right.
So my question is,
We'll just have some mementos. Dr. Khalil.
Oh, thank you. I didn't see anything when you are giving me.
Thank you so much. Thank you.
Dr. Ghazi, you want to say? Dr. Ghazi?
You can't say anything. This is a very good meeting and the information are plenty. The only thing for the future, if this will be repeated, to give more time for the speakers rather than to keep running and then you will follow what he said.
So then we need 2 days actually. So yes, well taken.
Just a small comment,
Yes, question.
If we see the last 100 years, the heart failure surgery or valve surgery, TAVR or TV, MBR, like first mitral valve intervention done in 1923 and this is 2025. So Idiot Cutler, when he has done the fractured valvotomy with the finger with high mortality rates. Then came to 1940s closed mitral valvotomies with the dilators. Then after John Gibbon, 1953, in 57 Lilly I done the first mitral valve repair. And in 60s Albert started the mechanical valve when things changed. Then came 62 when Ronald Ross, he has done the replacement of aortic valve with the pulmonary valve and pulmonary valve with the homografts. And then the tissue valve came, then Carpentier tissue valve, Carpentier techniques of repair. And then in 1984, Melun mitral valvotomy came. And afterwards, things changed. And these tissue valve homografts, they have given the a direction for the invention and valve implantation come. Then Alan Crepier, who has done the first tower 2002,
Yes.
he has done that in a high risk patient. And from there, things came to this level that they are going to take the mainstream valve replacement, particularly in aortic, and we see in future mitral valve is going to do the same. And same thing has happened with the heart failure surgery, as Dr. Sagi has said. This also changing the genetics and biomedical engineering, the way it is taking over. And we started from the Bethesda, wedge resection, abandon, then dynamic cardiomyoplasty, where we were wrapping the latissimus dorsi to the heart, abandon.
Yeah.
Then the core cap came and we wrapped it around the heart to stop the dilatation. And then the resection, DAW procedure, wedge resections. And now the genetic biomedical tissue engineering, which is taking place for the heart failure surgery.
Yeah.
So if we sum up these all things, we are going towards the genetics and biomedical engineering. So it's again a milestone what we are doing in the transplant surgery, in the failure surgery, in the valve surgery. These things are going on and will keep on going.
Yeah.
Thank you, sir.
Yeah,
Sir.
thank you.
We'll have only two quick questions
Yeah,
because so far we are maintaining the time, but we cannot go any more.
We
further.
can decrease the coffee break to 15 minutes.
And the coffee break, we are going to have a coffee break now.
Yeah.
So
We'll take the two questions.
Yes,
Thank you, Dr. Srinivas, for a wonderful talk and showing your data. We will just like to know what are most dreaded complication, 5 complication could be life-threatening you faced in your series.
No, let us discuss about some good things, right?
Okay, later on, in the coffee break.
In the coffee break, sir.
I just want to valve in valve, how many times it can be done? So one tower and then you have second tower, valve in valve. So how many times maximum it has been reported?
No, 3 times, but one has to be SAVR in between. So TAV in TAV is 2, 2. Second time TAV in TAV can be done. So one of it you have to plan for a SAVR. That's why the planning goes. Suppose you do SAVR at 50 years of age, then you do TAVR at 65 years of age and again at 75, 80 years of age. So 3 procedures lifetime are generally should be planned. That's how the thing goes. And regarding the dreadful complications you asked, sir, what beautiful experiences of TAVR I will tell you. Well, just to mention, one patient was shifted from somewhere distant place in Vizag with IV Lasix infusions. He was not able to lie down, surgeon refused, and nobody was willing to operate. He knew us, and then he came with the IV infusions. Once we did the procedure, 3 days later, he improved dramatically, everything off. And when somebody asked, the press or somebody asked them to tell what it is, he told, since last 3 months I couldn't sleep. This doctor took me inside, he did some procedure in 1 hour. This last 3 days I could sleep very well. So those are the comments which give us impetus that this procedure is here to stay. And then one patient shifted from Nagpur, not able to lie down flat, went to vote in the recent election. Those are very good stories we have for TAVR, to saving very sick lives. The complications we can discuss off level.
yeah, I'm so sorry. I have to please close the session because we are very particular about timings. And so far we have maintained reasonably well. You can please discuss on the coffee break. We are going to have a coffee break in 20 minutes, 11:35. We meet up again. Thank you. Wonderful. Wonderful. Thank you so much. Give them a big hand. Thank you.
I would like to invite Dr. Nushin for session 4. And again, Dr. Nushin doesn't need any introduction. She's actually a consultant with me in the Department of Cardiology at Dubai Hospital. She's a board member of the World Heart Federation, and she is a very active member of our teaching program, including the fellows as well as medical students. So she will be talking today about semaglutide beyond diabetes control. Dr. Nushin.
Thank you very much. Would like to thank the organizing committee of inviting me to give this lecture. I would like to actually thank you for spending your Sunday morning listening to all of these presentations. This is my disclosure, and I'm a cardiologist, but this slide is taken from IDF, International Diabetic Federation, and I'm sure there are some diabetologist colleagues among the audience this morning as well. So you can see that diabetes actually is growing like the cardiac disease. And this slide is the information from the Middle East and North Africa, MENA, which applies to most of us here. And IDF has predicted that in 2045, we will be facing 36 million patients with diabetes. And people with diabetes, on the other hand, have 2 to 4-fold higher risk of cardiovascular disease comparing those who do not have diabetes. Now, recently we have identified another window to look at the management of overall cardiovascular disease and diabetes. We managed to recognize that cardiovascular disease, kidney disease, and metabolic disease are linked quite together. Addressing one isolated disease will not prevent your patient or mine to live longer and to have a better quality of life. So the reason for that is because cardiovascular, kidney, and metabolic disease rarely occur in isolation. They share the same risk factors, and because of that, it leads to the severe outcome like myocardial infarction, stroke, and kidney function that can be fatal. So therefore, the management of the chronic kidney disease by itself requires a holistic, multifactorial, and person-centric approach, which is already suggested by guidelines. So my talk mainly today is about the link between diabetes, cardiovascular disease, and kidney disease. So in type 2 diabetes, we know that patients, they may have micro and macro complication, and you can see that all of these complications actually can lead to adverse major complication of advanced type 2 disease. Well, what we have done so far. So this slide tells you that we know one factor, that if we do not treat our patients adequately and with the appropriate treatment that can address these 3 targets, which are cardiovascular disease, metabolic disease, and kidney disease, your patient and mine will have increase in 7% of retinopathy, 18% of increase in nephropathy, 8% neuropathy, and 8% in stroke, 8% in myocardial infarction, which is translated into more of death as well. So overall, in high-income countries, we have about 91 patients of diabetes who have type 2 diabetes, And it has been shown that heart disease is the cause of death in more than 2/3 of patients at the age of 65 and above. And there are many pathology that has been linked to increased cardiovascular disease in type 2 diabetes, insulin resistance, the concomitant hypertension, hyperglycemia, dyslipidemia, obesity, endothelial dysfunction, and so on. But chronic kidney disease, which is a common complication of type 2 diabetes, has its own significant disease burden. And you can see again here the data that has been published that in 2045, we will have a significant increase in the number of patients who have chronic kidney disease. So in both type 1 and type 2, chronic kidney disease is very common to occur with patients with diabetes. There are multifactorial intervention that has been recognized, they're proven their efficacy in the reduction of risk complications in diabetes patients. We all know about platelet inhibitors, good glucose control, weight and lipid control, and last but not the least, blood pressure control. So the STENO2 studies showed that after 21 years of follow-up, if you control all of these risk factors, you definitely will delay the first time of the first cardiovascular event and the occurrence of the microvascular complication, which will actually translate into increased survival and decrease the events. Now, this is a what? Shakeheart. But I think one of the things that really shook the cardiologists and diabetologists, general practitioner, is the emerging effect of the agents which were used for the diabetic patients to see how much of cardioprotective and recently how much of nephroprotective they can be when we use it for our patients. So this was a shaking news, and I'm sure you have heard a lot of this news in the Shakeheart this year and the previous years as well. So GLP-1 receptor antagonists have multifactorial effects, but I want to bring your attention to heart and the kidney, and you can see that it decreases the inflammation, decreases the oxidative stress, and decreases RAS, which has been recognized for so long as a pathophysiology of cardiovascular disease. In kidney, it increased the natriuretics, increased diuresis, and decreased inflammation, oxidative stress, and RAS as well. What is GLP-1? GLP-1 is a human endogenous GLP-1, and it is secreted, and the receptors they have the receptor expressions. It is synthesized in the neuron in hindbrain by L cell of the gut. The semaglutide is a human GLP-1 antagonist. It is a 94% homology to the human GLP-1, and its half-life is approximately 1 week. So that is why when we all prescribe semaglutide, we actually prescribe it once a day. And this slide is showing you that we all, I don't need to tell you, I'm sure all of you have experience with this. We start with a low dose, we up titrate after 1 week, and the maintaining dose is usually 1 milligram once a week. So we know all of these factors, and I'm going to give you some information about all the universal guidelines. what is the role of GLP-1 in the treatment of diabetic patients who have high risk for cardiovascular disease and nephropathy. But despite of that, the studies had shown that less than 5% of the population with type 2 diabetes are treated with GLP-1. And this data was taken in UK in December 2019. And it was recognized that because it is an injectable medicine, this was a very important obstacle for the prescribing these medications. And then it was also studied that the median time for the diagnosis to first GLP-1 initiation was 6 years. It was 11 months, the median time spent when the hemoglobin A1C was not at the target dose, and 1.9 years of diabetic specialist prescription was made by the diabetic clinic compared to the general practitioner. So it was started late, but it is more commonly initiated by diabetologists. This slide is not from my presentation. This is a slide from our clinics. So these are the clinical inertia when it comes to initiation of the guidelines-proven medications when it comes for diabetic patients who have cardiovascular disease and who have nephropathy. So one of our common inertia is he has mild diabetes, or the patient is already stable, no complaint on the current therapy. Why should I change anything for him? It is inconvenient for him, for her, or even for me to spend time to change his prescription. And it costs me more time and headache to actually intervene and sit down and convince the patients that now we have new evidence that these medications can not only control your diabetes, but also can protect your heart and your kidney. So this is a global study capture, which was a cross-sectional study of contemporary prevalence of cardiovascular disease in adults with type 2 diabetes across 13 countries. I'm just showing you a couple of slides on this because the evidence is there that in diabetic patients, cardiovascular disease is very, very common. So treat diabetic patients with a medicine and with agent, with a class of medications that has not shown any cardioprotective, I think would produce a big question mark in the proper management of these patients. So this was the first global study prospectively captured the prevalence of cardiovascular disease in people with type 2 diabetes. It was across 5 continents, 13 participating countries, and you can see that it actually covered both primary and secondary, and you can see that 1/3 of patients with type 2 diabetes had already established cardiovascular disease. 9 out of 10 had cardiovascular disease with the atherosclerotic heart disease, and 2 out of 10 had a lower than recommended treatment. PACT MIA is the one exactly mirror image of the global study for our region, and you can see that the good presentation of the countries, and UAE was among all of them, perhaps had almost the highest number, and you can see that it showed that 21% of diabetic patients had established atherosclerotic cardiovascular disease, and the 30% had multiple risk factors for the developing cardiovascular disease. So this slide is showing you the proportion of people with type 2 within each ASCVD risk category according to ESC 2021 guidelines, and you can see the data that is taken from the UAEs has been highlighted in this. Now, achieving the ESC, which all follow for all the cardiology and the ischemic heart disease, primary PCI, hyperlipidemia patients, the ESC 2021 guidelines recommended target of risk factor by people with type 2 diabetes who are at high or very high risk factors. But again, they recognize that fewer than 4 in 10 with type 2, they achieve any of these risk factors that has been recognized, whether it is the controlled A1C, whether it is the control of blood pressure, whether it is the control of the lipid, and these are 1, 2, 3 that we learn in medical students. When you deal with diabetic patients, you look at hemoglobin A1C, LDL, and blood pressure. But later, when we all graduated, then we actually looked at the specific medications that can actually change the outcome of the patients, the prescription of the RAS inhibitors, GLP, SGLT2, and the BMI and the exercise and etc. So the potential emerging role of GLP-1 in type 2 and chronic kidney disease are summarized here. The kidney benefit is something new that has been recognized. And because of my first slide, you know that it is a very important factor in the cardiovascular disease mortality and morbidity. The mode of action which the GLP-1 can provide its kidney benefit is currently not well understood, but likely involves the combination of both direct and indirect effect of GLP-1 receptor antagonists. The indirect one, the improve of glycemic control, the reduction in the blood pressure, weight loss, and the direct one through the natriuresis, hemodynamic effect, endothelial function, and etc. Now, these are all of these cardiovascular outcome trials that has been done for GLP-1 receptor antagonists. And I'm just going for the sake of time to mention this study, which is the semaglutide and cardiovascular outcome in patients in type 2 diabetes. It is SUSTAIN 6, which was a time and event-driven pre-approval trial conducted to assess the non-inferiority of semaglutide compared with placebo in terms of cardiovascular safety in subjects with type 2 diabetes. And you can see that there were 4 arms, semaglutide 1 and 0.5, and the other 2 placebo arm. And patients who were living with type 2 diabetes were included. I want to bring to your attention to the primary outcome. The primary outcome was time to occurrence of MACE, which was summarized as cardiovascular death, non-fatal MI, or non-fatal stroke. Now, overall, the hazard ratio of the study was reported to be 0.74, which means that it actually reduced the primary outcome in total by 26%. But if you dissect the primary income for this primary outcome in this study, which I enumerated for you, and it was 3, if you remember, cardiovascular death, non-fatal MI, and non-fatal stroke, you can see that actually the benefit was mainly driven by non-fatal stroke. And you can appreciate that it actually reduced the non-fatal stroke by 39%, something that I think is very important for your patients because nobody wants to live with a stroke, and also even for our colleagues in a stroke unit would be very, very interesting. And also we had the change in the hemoglobin A1C comparing of both those of the semaglutide comparing to placebo, as well as the reduction in the body weight. So semaglutide reduced the nephropathy in people with diabetes type 2, and the adverse effects that we had were comparable with the placebo, and very few patients actually had serious side effects. So there was a 26% reduction in the primary outcome, and the number to treat was 45 for 2 years. But we had patients who had actually complication with retinopathy. The FLOW trial was a trial which was designed to study patients with diabetic type 2 who already had chronic kidney disease, and we wanted to see whether semaglutide actually has its own effect and how much of kidney protection it can produce. So it was associated, semaglutide in chronic kidney disease patients was associated with 24% reduction in the main 5 component of composite outcome that you can see on the left side of the slide. But again, this was mainly achieved by reduction in the urine albumin creatinine ratio. And the safety again showed the same safety profile as I mentioned. The guidelines, all of this evidence actually has been translated into the guidelines, and now guidelines for the hyperglycemic control of patients with type 2 diabetes, actually the ESC guidelines was the first guideline to recognize their main role of SGLT2 inhibitors and GLP-1, and accordingly, after these guidelines, also the other diabetic society guidelines, they follow the same thing. So, ladies and gentlemen, in these days, treating diabetic patients who have moderate to high risk of cardiovascular disease and nephrology and renal disease no longer translate into only control of hemoglobin A1C. We have to intervene with something that can protect both heart and kidney as well. My last slide is the cooperation of the Emirates Cardiac Society and Emirates Diabetic Association to come with the guidelines. And what I like about these guidelines is that actually they emphasize on the risk stratification of the patients. So if your patients has moderate to high rates, then you really have to change the chapter and change the page and look at the medications that can be beneficial for your patients. With that, I would like to thank you. I'm sorry I talked all.
I think we need to move on. That's what, we're a little running behind. So maybe you can ask her during lunchtime or something.
Thank you, everybody. And now we move on to the next session, which is another very interesting session after two wonderful highlighted talks. And
This session has two keynote lectures, and we are going to have lecture number 2 first and lecture number 1, AI in healthcare, second. We have slightly reversed. So lecture on acute myocardial infarction is pre-recorded from Professor Peter Kala, and that will be played first. So our chairpersons for this session are Professor Peter Kala, who may or may not join online. He is not available here. He's in chairs. The other moderators are Dr. Abdullah Al-Hajri. Is he here? Dr. Hajri. And Dr. Ajit Jain. And Dr. Rajesh Rai Pancholia. Please come over the dais in the stage and start with the lectures 2. So lecture 2 will be. Mike.
So we are starting the session 5. Keynote lecture is by Professor Peter Kala online, that acute myocardial infarction with cardiogenic shock, how to improve outcomes. Professor Peter Kala is head of the Department of Internal Medicine and Cardiology at University Hospital, Czech Republic. Over to Dr. Peter Kala.
And I just want to add that Professor Kala has been part of this faculty in each and every conference up to now, starting from the first one. So consecutive 9th year he is participating, but last 2-3 years he has not been able to come in person. So his talk is recorded online. Please.
Hello. My great pleasure to be with you, and I would like to thank Dr. Rajesh Mittal for his kind invitation for the 9th annual conference of Shakeheart. That means saving deaths and damages from heart attacks. My theme will be acute myocardial infarction with cardiogenic shock, how to improve the outcomes. If you are talking about the cardiogenic shock, there is a quite good classification. That means the SKY classification. And what is for us extremely important is the phase deteriorating and extremis. And that means this part here, significantly increasing the mortality. Before that, there is the shock at risk beginning and classic 1. What this classification lacks is hemodynamic criteria and does not differentiate between univentricular or biventricular shock. The pathophysiology of cardiogenic shock is quite complex, in fact. And it's about hyperperfusion, it's about vasoconstriction, congestion, and marked vasodilation. And the clinical scenario after that is can be very different. That means it can be from a venoconstriction till to sears and cytokine storm with microthrombosis and mitochondrial damage. The problem with cardiogenic shock is that this doesn't affect only the heart. It's a multi-organ failure, and the hematology impact has already been said. But besides that, it is bacterial translocation, endotoxins, etc. Renal failure can be hepatic failure, and of course pulmonary one. The complexity of pathophysiology very nicely demonstrates this algorithm, this graph. Maybe what is quite important for us today is the role of mechanical circulatory support. And it can be myocardial dysfunction, of course. I'm talking about the acute myocardial infarction. And what can be done by the mechanical circulatory support device? So we should, and we can, nowadays prevent worsening of systemic inflammation, prevent progression to vasoplaque shock, improve systemic perfusion, improve blood pressure, and prevent hypoxemia. That means we should reduce the ischemia and increase the coronary perfusion. And by that, all that, we should prevent the death. And after that, the patient should get back to quite good quality of life. Some examples. This is quite simple scenario. One vessel disease, inferior ST elevation, myocardial infarction, hemodynamically stable patient, and simple hospital course without complications, and he was discharged home at day 5. This is quite different scenario. Triple vessel disease with plus cardiogenic shock in male, relatively young male, 56-year-old, only from the risk factors hypertension. And there was triple vessel disease, acutely closure of circ, is visible here. Significant lesion of left main coronary artery disease and LAD, and the CDO of RCA, and this was the left ventricle ejection fraction. So very, very bad situation for the patient, and difficult hospital course, including CPR, ventilation, and mechanical circulatory support. In this case, we used VA veno-arterial ECMO plus balloon pulsation. And during the index procedure, it was done PCI plus DES of circ, and as a stage procedure, we did PCI plus DESs of left main and LAD. And after that, after discharge home, the patient was rehospitalized several times, and but finally, after 1.5 years, he was treated with heart transplant, and he's in good shape now. And in the middle, between these two scenarios, you can see here, male, 61-year-old with anterior ST elevation, myocardial infarction, and cardiogenic shock, and there was very, very tight thrombotic lesion in the left main, the dominant left main. You can see that the right was relatively small, so practically the whole system was, the whole left ventricle was supplied by the diseased left main. And what was the course? And what we did? So we implanted impeller system, but it was necessary also to resuscitate with the automatic system. Here you can see, and but this is the final result. Quite good result at the end with including the impeller CP in place, and relatively simple hospital course without complication, discharge to community hospital at day 7. Is it necessary to treat all the lesions, all the vessels that are diseased? And cardiogenic shock patients are the exception from the standard approach to make the complete revascularization. And especially during index procedure, we have very good data that we should treat only culprit lesion, culprit vessel. And you can see the composite primary endpoint from the culprit shock trial. And the culprit lesion only PCI was associated with better results at day 30 than multi-vessel PCI. And the same was true for death from any cause, all-cause death. And non-significantly, but better results were achieved also by the renal replacement therapy. And these are the 1-year data, and practically the same results. So culprit lesion only was better than multi-vessel PCI. And so that was the randomized trial. But we have the registry, national, from Poland, a national registry from 2 years, and propensity matched analysis according to culprit shock trial. And you can see practically the same results. So that means the culprit lesion only PCI was better than multi-vessel PCI. And this is all-cause death at 1 year. And you can see that at 1 year, the results still are definitely not perfect. We would like to have much better mortality than 50 or more than 50%. One of the possibilities is some different approach. And this is one of suggestions, Rose approach. What does it mean? Recognize, rescue, optimize, stabilize, and after that de-escalate and exit the therapy or support. We have the golden hour, like in STEMI population, and so early identification of patients with cardiogenic shock, that is crucial. We have the hemodynamics, we have SCI, of course, staging, and phenotyping. The phenotyping at admission should divide the patients in several groups: non-congested, cardiorenal, hemo-metabolic, and of course congested, to gain prognostic information. And again, we are focused on patients with deteriorating cardiogenic shock and extremist cardiogenic shock. And what is quite important for us to know, and for the patient, of course, as well, is the worsening of the left heart failure or the right heart failure or B ventricle failure. And there is some algorithm what we should use. We can use VA ECMO, temporary LVAD, biventricle assist device. There are primary considerations about the phenotype and secondary considerations. Because nowadays we have quite good possibility for helping the patients. We have the mechanical circulatory support, of course, a very long history with counterpulsation, the pulsatile, but not very effective support. And we have the Impella CP or Impella for surgical implantation. So we have support of 3.5, maybe up to 3.8, 9, that can be done by the percutaneous approach. And for the surgical approach, it can be 5.5 liters support. And after that, well, not exactly tandem heart, but veno arterial ECMO. And we have also some possibilities for the right ventricle support. So if we have hemodynamic problem, we should be quite fast and try to help the patient and to recover his hemodynamics. Because after that, the shock continues. So it's really very difficult situation. Hemo-metabolic problems and multi-organ support. So we can, at the beginning, we can start with simple devices, but after that, it has to be more complex approach. If you are talking about the veno-arterial ECMO, we have the CLS trial, extracorporeal life support, and the primary endpoint was all-cause death at 30 days. And unfortunately, the VA ECMO didn't have any really good impact on the outcome of the patient. So it was more than 400 patients included in the trial. And the price for using this system was quite high, but not surprisingly. There was a higher risk of moderate or severe bleeding. You can see the CLS group versus the control group, and also the peripheral ischemic vascular complications warranting interventions. Again, higher in ECLS group versus control group. And we have very good data now for Impella. Danger shock, randomized control trial in STEMI with cardiogenic shock, 360 patients using microaxial flow pump or standard care in infarct-related cardiogenic shock. And you can see the results. The death from any cause at 6 months was significantly lower in the microaxial flow pump than the standard care. Again, the complications rate was higher, and it was severe bleeding, limb ischemia, hemolysis, device failure or worsening of aortic regurg. You can see the data here, 24% after using microaxial flow pump and versus 6% in the standard care group. What is the percentage of population included in the randomized danger trial? From the registry, cardiogenic shock registry, it represents only 8% of STEMI cardiogenic shock and 1% of all cardiogenic shock population. So it's a relatively small percentage, but extremely important. And if you compare the danger shock versus ECLS shock trials, you can see that 30-day all-cause mortality, 6 months all-cause mortality was significantly better in the danger by using the microaxial pump, but practically no advantage in ECLS. What we are waiting for is the results of the DAPT shock AMI trial. That means cangrel-based initial antiplatelet strategy in patients with AMI and cardiogenic shock. Now the enrollment of the patient, the database was locked, and we are waiting for the analysis. It will be quite important for our interventional community. So how should or how could we improve the outcomes in patients with acute myocardial infarction with cardiogenic shock? Still, time is muscle, time is life. It's extremely important. So we should be very fast at the beginning without any delay, and we should make the proper decisions in time. And the primary PCI is the winner for STEMI and very high risk NST, acute coronary syndrome. Of course, there are technical aspects of primary PCI. We should go radial. We should use DES and backup intracoronary imaging. The counter-arterial vascularization during the index procedure, definitely. And we can discuss the optimal strategy after that, if it should be staged, complete revascularization, or very selectively. And role of mechanical circulatory support, especially Impella CP. If it is not enough, we can expand for veno-arterial ECMO, and we can use both systems together. It calls ECMELA or ECPELA, or we can combine it with counterpulsation. And we are waiting results of that shock trial regarding the optimal antithrombotic regime in patients with cardiogenic shock. So thank you very much for your kind attention.
Bala is not available, but on this context, if one or two comments, quick comments, we can have, or some discussion quick, and then I'll call upon the next speaker about cardiogenic shock. So we move on to the next speech, which is away from core clinical cardiology. That is artificial intelligence in healthcare. We welcome Professor Peter Fitzgerald from Stanford, and we are all excited. And in fact, I got many queries when people saw the agenda, and many of the delegates, Dr. Peter, were especially enthused by this talk, and many of them are listening online. So most welcome, and please, we are waiting to hear from you.
Great, thank you, my friend. And ladies and gentlemen, I'm between you and your lunch. So that's not a good place to be, but I'll try to make it entertaining, and hopefully then we can have a nice lunch. I was born in Silicon Valley. I work at Stanford, which is at the bottom of Sand Hill Road. I live on the top of Sand Hill Road. 48% of all the venture money in the world comes from those 3 blocks. And so this is going to be a little bit provocative, but it's going to be digested from where I live. In the late 1999, 2000, we saw the internet come here. It was way overvalued and it crashed. We're seeing the same thing right now with AI. It's way overvalued, but the difference is that there's a ledge of products that can be accelerated by these large language models, by AI. That's the difference. But still, it's about $1 trillion overvalued by the people that I live with on Sand Hill Road. And some of the issues related to its expansion are energy. The amount of energy that it needs for GPUs is astronomical, and the amount of water you need to cool those systems are astronomical. So it's not just the over-evaluation, but there's some practical skirts on that process as well. Just to briefly talk about large language models, It's a collection, it's a digestion of trillions of data points from scientific papers, EMRs, FDA, PubMed, and then a large sweep through private and public processes. Now, rather than doing human curation, you do digital curation. And what that means in those trillion data sets is you take out data, rerun it again, and see if ultimately you can predict what you took out. And you do that many, many times. And you end up with a very large, somewhat high fidelity training set. But now we need to fine tune it with labels, tokens, clusters. A cluster is just connecting an image with a word to get to, again, what we're talking about here, a training set, a neural network for acute MIs, or for heart failure, or for electrophysiology. And that generates then predictive AI, which is forecasting, and or generative AI, which can come up with outcomes that you did not expect. And that's the power of it. And the amount of data worldwide, 30% is in healthcare. So we have one of the largest opportunities I've ever seen in my 30 years of practicing medicine to really get standardized, more efficient, and more effective for patient care. This is an article from Google that says Google can tell you more about your health and maybe have a better bedside manner than doctors. The dirty little secret here is that good doctors know how to do. We've seen that in these amazing talks today. Better doctors know when to do, but the best doctors know when not to do. And the data sets that we're accumulating as these training parameters do not include the latter. So we are going to be an important component to this accelerant of AI. Where you're going to see it in the clinics first, and we see it today, is you're going to see an administrative task, conversational AI, to be efficient in rescheduling, to be efficient in scheduling. You're going to be able to see conversations that immediately go into the EMR through natural language processing. The coding will potentially, and is today in the United States, being done before the patient even leaves. So we go after the insurance coding before the patient even leaves. Conversational AI, revenue cycle management. Those are the sort of subtle issues that are going to streamline the efficiency of care. Now, the exponential collision is an example of what we do every day. 7,000 primary care articles are published per month. And it's what we call the TLDR. It was too long and we didn't read it. But that interaction is what a computer can do within an hour. So this neural network on the left, which is 299 parameters, GPT-4 consists of 1 trillion parameters. So it makes this interaction that we do every day much, much easier. For example, humans have problems when there's a lot of choices. We analyze, and that analysis often leads to paralysis. But in seconds, a large language model can give you a heuristic ranking of what you should be discussing. It may not be the optimal answer because we need doctors, nurses, PAs, nurse practitioners to give you the bumper cars, but it focuses the discussion. So here's a young doctor. She just got out of her practice. She's working with a guy named Joe, who's complex. As we heard from the hypertension talks, he's got HFpEF, he's got diabetes and a single kidney, and his blood pressure is not controlled despite 2 medicines. She doesn't have the experience yet to treat Joe effectively. So she calls the head of the department, man or a woman, to try to get their experience. But they're always out to lunch when you need them. So in a microsecond, you can get a heuristic argument of what this young doctor should do with Joe. And it doesn't mean it's the answer, but it provides a heuristic, stochastic recipe, if you will, for this complex patient. We encounter patients that undergo MIs, CHF, kidney disease. They engage us. They come to our hospitals. But we need to think a little differently by combining the data with our clinical attributes. And we should go upstream. And what you're seeing today is a flood of people that really know how to engage, from CVS, Walmart, Google, to NVIDIA and Palantir. So we need to go upstream, potentially to provide parameters before they need some of these episodic technologies. Just to take a line out of Desmond Tutu in 1984, there comes a point when we need to stop just pulling people out of the river, but we need to go upstream and see why they're falling in. That's the opportunity that we're on the precipice with some of the AI issues. Point of care, you all have seen point of care ultrasound, to be able to do things at the patient's bedside or out in the rural areas where they don't have such an opportunity to triage or to screen. We use AI today to orient, qualify, and quantitate the angle of the transducer in the intercostal spaces so you can get an immediate quantitation of left ventricular ejection fractions, the competency of your mitral, tricuspid, and aortic valve, all by having this brought to you by AI through the cloud. This is a small little device. This is my living room. My daughter has never done an echo, but by having the AI orientation, she's able to get my left parasternal view on the couch in my living room. These are going to be important issues with respect to the dissemination and care processes beyond the hospital. This is a device that goes on your chest. It's the size of a credit card. And within 20 seconds, it gives you a full 12 lead EKG. And that can be then read in the cloud by a doctor. This is working today. And think about that in the context of what we've been talking about today. Being able to triage chest pain in a rural area or even at your home. And to make sure that some of the EKGs that you get in the clinic or in the hospital are the same. This is the page writer from Philips on me on the left. And this is this device on the right. Even when you have arrhythmias, it's very accurate. And you can see the difference of this conduction defect here. One of the things that we're learning is that there are subtle defects and subtleties in the EKG that we're not used to reading. And you can impute those from large databases. This is a database out of New York, 77,000 12-lead EKGs. Remember, there's 70 million EKGs done per year in the United States. And from those subtleties of an echo that was gotten within 6 months of those 77,000, you can begin to impute left ventricular dysfunction or valvular disease. Again, a mechanism with data and overread in the cloud to direct and triage folks more effectively. And when you do recognize an acute MI somewhere other than the ER, we've learned by door to balloon that the quicker you get from home to the door is a broadcast of what you subsequently will have with respect to heart failure. And those different classes of heart failure after you've had an MI are significantly correlated cost. So again, home to door needs to be refined because today we're doing a pretty good job in door to balloon. And being able to not just do this in Chicago, Boston, or New York, but be able to do it in some of the rural areas. These point of care technologies coupled with data analytics and overreads in the cloud is going to be a component to increasing the efficiency and the efficacy for our patients. Again, they will triage folks in rural areas into medical centers when they need it, the right patient at the right time for the right technology. And they can get that episodic care when it's appropriate in the hospitals. We've seen a number of dynamic processes that you can get your coronary assessed in an outpatient setting. We've seen that it's very similar to what you can get in a cath lab. We've also seen we can overlay physiology on top of that, anatomy and physiology, before we even think about going to the cath lab. Well, today in the cath lab, you can actually do the same thing through AI by comparing the morphology of your angiogram to many, many FFR wires. And this was done for hundreds of thousands of cases. And so what you do is you're able to then impute the FFR, the physiology in the cath lab instantaneously on top of the angiogram. In 3 dimensions, you're able to, rather than pushing a button or pushing a catheter, you push a button. So that you're able to get physiology on top of that morphology. And that way, in Streamline, in the cath lab, you're able to get both of those features to direct better outcomes for your patient. So in conclusion, it's one of the most exciting times I've ever seen in medicine. AI will grow exponentially in health because 30% of all the world's data is in healthcare. And those that don't adopt it, you will be left out. Large language models will be the basis to learn, formulate, and predict most efficient pathways for clinical outcome. Like we talked about, the right patient for the right technology. Democratization and dissemination of these technologies will be important for making care effective. And we're going to see a plethora of these tools at our fingertip in order to standardize care, make it effective from hospital to home and all that in between. Thank you for your attention.
So it was an excellent presentation. Any comments from the moderators here?
The session is open for the question answer.
Question answers.
Anybody?
Yes, Dr. Amir.
Thank you for an excellent talk. I heard you mention a term that I find very exciting. You said home to balloon time. And do you think in the future there will be wearables where someone would have a STEMI, for example, sitting at home and it will automatically set off a dominoes of events where essentially you will be tracking home to balloon time rather than paramedics or pre-hospital first medical contact time?
There you go. I think that's going to be one of the factors that, for example, you would judge in addition to their background, in addition to their clinical presentation, their story of their chest pain with ST elevation or suppression, and then be able to get them to that node of the next stage. And I think that when you really look at, and we've all been in the emergency room when you say, well, Joe, when did this pain start? Well, it started tonight, but it was there 2 days ago. And, there's those lingering stories. And I think that's the component from a clinical perspective, but also a cost perspective. And so we're working with a number of the insurers to try to tighten that up because that has a very huge cost associated with it. Yes, sir.
Yeah. Yeah, Dr. P.K. Gupta. We have few minutes, couple of minutes for discussion.
It's a wonderful lecture, and I think AI is going to revolutionize, especially the field of cardiovascular. Whether you talk about EKG, whether you talk about imaging, whether you talk about CMR, in every aspect, it's going to change. Just giving you a few examples about the echo. As you have shown in POCUS, now we have got a wireless transducer and our mobile. And just we synchronize and we can do echo anywhere. And the mass screening is done in the rural camps. So it is much more efficacious as well as time saving. And there's plenty of data which compared the cardiologist as well as just trained nurses. And with AI algorithm, they perform better than the cardiologist. So it is going to really revolutionize the imaging as well as therapeutics.
The only comment I would make to that is I don't think it can do better. I think we have natural guardrails here, and it's the healthcare professionals that get the information but still make the decision. And I work a lot with the FDA, and as long as you keep those guardrails that the physician or the nurse or the PA, NP makes a decision, then you have those guardrails. Your Tesla can go out of bounds. But the issue here is that we're not going to replace doctors. We may redistribute how people work a little bit, but we're not going to replace doctors. So they will at least present a hierarchy so that you can make the decision better.
Yeah, but they are much efficacious. The echoes which you do in 2 hours, suppose 20, you can perform 50. So there is a lot of time saving.
You bet. You bet.
Yeah, Dr. Samir. Mike, give him a mic, please. Perhaps the last question, then we'll move forward.
Thank you very much for the opportunity to listen to you. This was a wonderful lecture, and it's an eye-opener for many of us. My question is a little different. You mentioned something about the costs, that if we don't recognize disease in time, it has a cost implication. So this question is related to that. When we get to the stage of predictive AI, which can predict today, if 10 years down the line I'm going to have a disease, how does it affect my insurance premium? Because this data will be shared with the insurance companies as well, isn't it? So this is a tricky question, I know. It's a slightly off topic, but I would like your insight.
Let me repeat the question because it's a great one. Is if you can, with predictive AI or generative AI, which is more the possibility, and I have a risk factor that the insurance companies get that information, it might be deleterious to that. But you can say that about everybody. You're trained well enough to where you can look at certain people, a certain body mass, certain lifestyle, certain area codes, and you can predict that they are on a trajectory. And we saw a number of examples today. I worry more about the genes. I've got a number of companies where you have 4 to 5 million variants in everybody's gene. And to actually connect that with a phenotypic expression, that's direct evidence that you might generate diabetes, that you might, have kidney disease, or you might have a stroke at 45. That one I worry about. This one, not so much, because we've been trained to recognize risk factors anyway. This just puts them in a little bit more of a hierarchy to make the decisions quicker and better. But genes are an issue.
Actually, that was my next question, the AI and genetics. Because if you go, majority of our disease ultimately have some genetic variation which make us predisposed to that when environmental factor adds on it.
You bet.
And these genes switch on and switch off placed by environmental factor. So what is the AI going to do for that?
So no question about it that you cannot apply the training set that you derive in the United States to Chennai, because there's epigenetic factors, environmental factors that influence that. You have to come up with your own training set that takes in that genetic, epigenetic process in those training sets. Training sets are only as good as they come from very specific data. If you have data about men and their hypertension, you can't apply that to women. So you're absolutely right. And so we have to be very careful. I work in Taiwan, and they have the largest hospital in the world, but the data for them are not applicable from the data that we've collected in the United States. So you're absolutely right. It's the training sets, though, that you have to be careful.
Last meeting, I think the one who is working in genetics in UK, they have the highest genetic data of UK population.
Yep.
For last 20 years, they are collecting it.
Yep.
And now they're sharing it on payment. So you want to do any research, you can get all genetic data and you can do your research. So if this is put in AI, we can get a lot of information of diseases.
Should make a lot of people what, sorry?
Information of the disease, which is probably come out.
This is where drug discovery is going. This is where clinical trials are going. Today, if you have alpha 6, this is a real mutation, alpha 6, 7C, and you're a drug company that wants to do gene editing, you have to knock at a lot of hospitals' doors to see if they have those patients. Today, you can spend multiple countries and go find them there. So it's going to speed up some of this drug discovery for genetic treatments.
Dr. Rajesh, you want to ask?
Just one, how would you think AI in healthcare would impact the training of doctors? The reason I asked is that at the recent ESC conference, there was a ECG interpretation with AI for emergency, and the ECG would predict where the stenosis is. So, the A&E doctor then doesn't have to think, or how would it impact, the future training of doctors?
Remember, those are imputations. So you have to have a lot of angiograms.
Yes, they had fed, like hundreds and thousands
So
of
Google
protocols.
doesn't even talk to you in my neighborhood unless you have 1 billion. So this really requires a large, this is the law of
This
large
was
numbers.
actually available at the ESC, this program,
but
AI generated.
But I would be much more trustworthy if you looked at it and
Yes.
overseed it with your experience. So flip that around. How are we going to teach the young?
Yes.
I don't think we have to. The young, my kids don't talk on the phone. my kids use thumbs to communicate. They're all into this and have associated in most aspects of their life. I mean, they're just in their early 20s, right? So I think medical school training, did you ever take statistics in medical school?
Sorry?
Did you ever take statistics in medical school? Oh, okay, you went to a good medical school, whoever said yes. I mean, I took statistics in my PhD of engineering, but not in medical school. Did you get taught how to have empathy with people in medical school? Absolutely not.
No.
You either had it or you didn't. So there's going to be room for incredible improvement here, which I look forward to. And the kids, I think, will envelop that.
Thank you so much.
Thank you. I think we should move forward. And first of all, I will say many, many thanks to Dr. Peter, and we would like to present you this plaque. Rajesh, please. Friends and colleagues, bear with me for 10 minutes only. This is a very short session of little welcoming and felicitation and thanks. So, and soon after that, we'll break for lunch. So, Jitin, can you please start?
Dear friends, I am extremely happy to know that the Shakeheart conference has reached its 9th edition. That's a big milestone. This year's theme, Saving Lives and Preventing Damage from Heart Attacks, is very relevant. My sincere appreciation to Dr. Brajesh Mittal and the entire organizing team. You've done an outstanding job organizing this conference. Your dedication to raising awareness and driving impact is commendable. This conference is an excellent platform. It brings together leading minds to share knowledge and expertise, which will help to advance the practice of medicine. I believe the discussions ahead will be meaningful. Early detection and timely treatment of heart attacks are critical. They save lives, and this event plays a key role in spreading that knowledge. I understand there are 25 lectures lined up, delivered by eminent doctors and surgeons. That's truly impressive. But beyond knowledge, this is about making care more effective and ultimately making a difference in people's lives. Wishing you all a productive, insightful, and successful conference. Thank you.
Thanks to our chairman for his patronage for this Shakeheart. Friends and colleagues, this is 9th annual meeting, and we had founded this in 2015 with another name, and the refoundation with the renaming was done in 2019. And many of you have attended continuously for last several years. This obviously requires a huge effort from your side to contribute and to listen to me and to listen to my urges, to settle with my topics, which I suggest to keep in time and come on time. So I have many, many thanks from the bottom of my heart to make it all successful. It is because of you and all of those faculty colleagues who are online and offline, and those who are present in person have contributed immensely to this program. We have a wonderful team behind working with us, our people team, Mr. Jitin and Mr. Praveen and his team. And we have Joyce, who has coordinated with all the faculty members so well, and she is working so hard. So many thanks to Joyce, because we do not get much opportunity to thank our back-end staff. So thank you all of them. Then our industry has generously supported the program only based on the merit, and at no stage they had any power to interfere in the programming pattern or the scientific sessions. So we are very thankful to them. In the last few minutes, I will just give a token of honor, which is in the form of bouquets and flowers, to some of the very I would say persistently dedicated individuals who have contributed to this program. There are many more, but we cannot honor everybody on the same time. So this honor will keep happening, but today I have selected and chosen a few ones. And I have chosen only those who are available here in the room now. There are many who have been in the faculty and who are also going to be faculty even in the afternoon from abroad, and we are not able to give them an unprecedented token. So, interestingly, there are 3-4 honors which I will just call upon the stage and give. Friends, we always assume and understand the contribution of the faculty and the faculty which makes the program great, and obviously we are going to honor some of the faculty. But before that, I want to honor somebody who is not a faculty, who has chosen not to be a faculty, but who is so dedicated and so passionate to attend the program so sincerely right from 9:00 a.m. So a very worthy gentleman is here, Dr. Binbrek. Please give him a big hand. He is absolutely deserving person. This is a person who has encouraged me so much, his presence encourages me so much that this program, please sir. So first time we are starting with the audience honor rather than the faculty honor. Thank you. Our next honored person is none other than Dr. Rajiv Lochan. He's been my mentor, he has been my colleague, and he's attending this and has been giving lectures since 2015, the first meeting we ever did. And although he's my senior, but he listens to me what topic to take and how many minutes to speak. So thank you for for engaging with me. Thank you, sir.
Thank you very much. Thank you, Brijesh. I'm very pleased to be next to Dr. Binbrick. So my status is going towards him. That's one thing in the right direction. Thank you.
The next one is a prolific scientific person who is a master of guidelines by heart, Dr. P.K. Gupta. Always here, always very sincere. He is last 4 years, he is coming from India and he takes a deviated flight because his flight is also not direct, but he always comes, he always sits all day long and he encourages and he participates in the program. Thank you so much.
Thank you, Brajesh. God bless you. God bless Shakeheart. God bless all.
Thank you. Next is Professor Peter. Professor Peter. Professor Peter Fitzgerald. So his contribution today can be counted as a passion towards his work. We met in a train from Washington, D.C. to New York, and he was my co-passenger, and we got introduced, and he got enthused with the program, and here he is today. And he made all the efforts to come to here and deliver in person. Thank you so much. Please keep coming. And for today's last, I call upon Dr. A. Srinivas Kumar. He is a wonderful, wonderful structural heart interventionist, a great cardiologist. Could not make last year in person because of the floods and his flight was cancelled. So this year, we have the honor to have you, and thank you so much. With this, we break for the lunch, and we are thankfully on time, and at sharp 2:30, we'll begin our next session. Thank you so very much for being here. Enjoy your lunch.